We had the inauguration plan at 9 a.m. and it's going to be at 12 at noon because of some of our directives that had to adjust their agenda. So we're going to start with the star of this session, Dr. Deborah Kestel. It's an honor that Dr. Kestel is joining us, and she destined some time of her agenda to be with us today with this starting speech. I'm going to introduce her. Dr. Crestel has a mastership by the School of London, also in psychology by the University of La Plata. She is current director of the Department of Mental Health and Abuse of Substances in the WHO, and she is in Switzerland. She has been in multiple charges. She has been a consultant of mental health, a regional consultant of mental health, and chief of mental health of WHO. She's the first Argentinian woman psychologist responsible of mental health globally. She has more than 25 years of experience consulting governments with about the systems of mental health for the institution alone and all the strategic partners. It's an honor to have Dr. Crestel here, who I give the floor now. Welcome, doctor. Thank you very much. Just checking if you can hear me. Yes, we can. I am not allowed to activate my video. I don't know if they can help me with this, please. So you can also see me and not just listening to me. Just a second, doctor. Well, in the meantime, I would like to thank your invitation and your introduction. I've never been called a star, so thank you very much. There's always a first time for everything. I'm very thankful. I prepared a presentation that is a summary version of the global report on mental health that we launched recently. So I'm just making some time. If there I am, can you see me? I can see me. I can see myself with a very nice background, a very weird background. That's the for the background for the action plan for mental health. So now that we see each other, thank you. It's a privilege to be here, even remotely. I'm going to share my screen. As I was saying, I'm going to show you a presentation of this summary of the report that we launched a few months ago. Can you see it? Can you confirm, please? Can you see my screen? Yes, doctor. Okay, thank you. As I was mentioning, this global report on mental health and substance abuse with this title, which is Transforming Mental Health for Everyone. What I prepared is a tour of the different components, chapters, sections of this report, expecting that maybe this will create some interest in you so you can find it and read it on your own. For the moment, the summary is available in Spanish, and hopefully in a few months we will have the full report in Spanish and not just the executive summary. Thank you to the collaboration of the regional offices of WHO. So what we include in this report, on one hand, is what do we know, which are the principles that we consider relevant, and which are the basis for this transformation. Then we describe a little bit why of this transformation, the benefits of this transformation, always with data information coming from many different realities. And also we include the path for this transformation? Which are the strategies? What do we know of the countries? What has worked? What hasn't? What do we consider that we need to do? There are many examples of cases of countries, examples of countries, and experiences of people who have lived and gone through moments or situations in their lives regarding mental health, but also the services, existent and non-existent services, the lack of it too. This is a little bit present all around the report to show what we're talking about, which is not only a theoretical conception of what it should be, but what is really happening in reality of each one of us. In the second chapter, we talk about these key principles. We are not saying anything new, but we believed it was important to be clear, to, as we say in English, to be written in black and white. What are we talking about exactly when we talk about mental health? You're going to find these key concepts and definitions. These are not necessarily new, but we need to review, we need to they are discussed for these reports, so we make sure that we are talking about the same thing and that we are on the same channel referring to a shared concept. So these key principles that you have here on screen, the basis is that mental health should be complete, should be integral. It's a basic health right. There's no health without mental health, so mental health is also a basis right. And it is also important for conceptualize everything. It's not only a problem of the health sector. Mental health is necessary to be able to connect, to be able to function in the reality, in the community, the society we work in, to have challenges, to be able to overcome challenges and move on with our lives besides these challenges and with the resources that we can find. Then we do a detailed analysis of data. That's the third chapter. That's the data chapter. We include everything we know, the data that we could gather and that you can find in this slide, very basic data that I believe maybe you already know, or at least most of the 3,000 online people. Congratulations, we're a lot. But I believe that those who are online know that 1 in 8 persons live with a mental health, that it affects women and men, young teens, and also elder people. 1 in 100 deaths is due to suicide. That most of these suicide happen during the active life of the person before they turn 50, and that 1 in each years lived with these capabilities. 1 in 6 of these capabilities are related to mental disorders, and that people with severe mental disorders died between 10 and 20 years before people who have none of these type of disorders, regarding health issues that could be prevented or taken care of or avoided or even recovered. But the only fact that they have a serious mental disorder, these or the other health problem is usually ignored. So this is some of the most relevant data that we consider to justify what we are promoting. We also, with the data, we have a lot of gaps in different sectors or from different perspectives. As you can see here, we see gaps. This means that the available responses or answers are still not enough or are wrong even. So we have information. Sometimes it is surprising the lack of information that we have. Uh, Even developed countries that could have way better information about this. Uh, Also, governance, we've seen that there's an increase in the number of countries that have plans and policies regarding mental health. But when we ask them how many of these plans or policies are implemented, turns out that it's only 20%. On the other hand, human rights, that in many countries, there's even though there's a little improvement, they are still not considered. I don't know if you can still hear me fine. I hear something. Okay, I assume you can. Another topic about these gaps is resources. When we gather the data, you know that if every 2 or 3 years we gather information data to see the development of countries in their commitment to implement a global mental health plan. And when we saw the atlas of 2020, we see that actually the budget for health destined to mental health hasn't changed since 2017. There was already an increase of attention, interest regarding mental health. However, budget dedicated from the governments to mental health is still 2%. And in the countries, especially in low income and medium income countries, 70–80% of those 2% is still destined to psychiatric hospital, traditional psychiatric hospitals, which, as you already know, these are structured that centralize the attention, and we're going to go further into detail afterwards. So there's no space to develop mental health services in a communitary level, which is what we are promoting since Alada in the 70s. So we are well behind. So from the point of view of services, there's no plan implemented. So if there's no developed for services, if there are no resources, obviously there are no services. So most of the people with mental disorder or with substance abuse do not have access and do not receive any type of treatment and do not receive any quality services. So we go then a little bit on why the changes and which are the benefit of these changes, like public health, which is what we're interested in, human rights also, and social and economic development. I'm not going to go into detail, but briefly, from the point of view of public health, there's evidence of a well mental health having an impact in the health, general health of people and the individuals. It's pretty obvious, however, is not necessarily considered. So while reducing suffering, the investment is going to is going to affect a lot of levels, like physical health, comorbidity, and impact a lot of another physical conditions. And there you have some numbers seeing the impact to understand the impact. There's a lot of studies that have proved this, and this is why it is included in this report. And this is from the perspective of public health. From the perspective of human rights, there's a human rights of convention for protecting the human rights of people without with capabilities. And some important numbers show the path to follow. It is not a technical or theoretical proposal, but just a commitment by countries to say, okay, we need to prevent the violation of human rights and a series of actions that need to happen for this to become reality. Obviously, abuses, which are still very frequent in regarding mental health, and also the autonomy and the decision making. So those persons who role with roles and life experience regarding mental health need to promote and need to have more space, and we expect more of these people with experience. Here we have some of the tools available, like Quality Rights, which is a tool for the capacity building to fight for human rights and mental health. And lastly, the social and economic development. A person who is well from the point of view of the mental health, even if they have a mental disorder, they may have a well situation. So it's gonna that person is gonna have a different role in the society and in the context they live in. And depending on this context and the situation, maybe a possibility to be productive in their community, in the sense whatever that means, because they work or because they contribute in their family, their community in a different way. I mean, it's not necessarily to be productive in the money sense, in the classic sense. But this does bring economic benefits for that person, for the community, and for the economy of that place. About reduction costs for health, increase of productivity, and the consequence that the community will have as an investment. I just realized that I didn't translate the graphic. I apologize, but it's you can see that it is a cycle, one action having another as a consequence, and that completes a chain that contributes a social to this social and economic impact. Then we have the chapter about the basis for change, which are the contexts, the existing structures, the agreements that already exist regionally, globally, and what do we know about this? On one hand, there are three types of commitments. I just realized that I have another parts untranslated. I apologize, but there are three types of commitment that are needed to move forward with this agenda. On one hand, the commitment, the expressed commitment, which is something that is changing, that is increasing. We talk even more. We talk more about mental health, some countries more than others, but in general, we talk more about mental health in most regions and international global health parameters. It is mentioned that mental health is important and there should be something done. So that is something moving on. Also, the institutional commitment, where that goes more locally, nationally, or regionally, of the policies, plans that they create, and we need to explain how we're going to reach to this goal of mental health. We're also moving a little bit on that, but slowly, but we are on it. And lastly, the budget commitment. That's the one that is going the slowest, not only in a country level. If we see colleagues from the Pan American Health Organization, maybe they will share the budget in the region of the Americas, but in general, there's a lot of a big difference between the US and Canada and the rest of Latin American and the Caribbean and countries a good part of countries of low and medium income of this region, they spend 1% or less than 1% in mental health. So there's still a long path to follow if we want to move forward on this, and if we want to adequate the public health of the country to what's really happening to the population, and not stay in this historic model. From the competencies point of view, we're going to talk about, we're going to go into details later, but how we can improve health and the outcomes. Maybe I see that I have a lot of slides in untranslated, but I guess I have the wrong file. I apologize, but what we're talking about is the role that each sector has regarding these matters, the knowledge, the competencies that each one has and need to move forward, and how we specialize even more. This is not new, but it's still kind of recent. Historically, only health professionals and specialists in mental health had something to say about mental health, like psychiatrists, psychologists, and some other specialists, maybe social workers, nursing. But what we're saying now is that each one has a specific role, since the individual that's going to work from their own experience and share and look for support, look for solutions, but also to build and to build together with other people that may be in a similar situation, and also the work of the social workers. In Mexico, there was a lot of work done a few years ago, how to co-work with health promoters and the role they have in identifying and do follow up to those people who have certain needs once they are back home, what type of psychosocial interventions they may receive. We also have the general service providers like general nurses, social workers, that with a adequate training, and Mexico has been working on this, they can detect, manage a series of conditions, priority conditions that are predefined, and they can work with when to refer and do follow with certain specialists when it's needed, or the social worker when it's needed, and do the follow-up for both levels of specialization and detail. And lately specialists, a specialist that is trained during 6, 8, 10 years in specific matters of mental health needs to follow that knowledge and that experience to apply it in more complex cases and to the most difficult situations, to support and follow those who are working in the primary care, to supervise and train how to receive references and give feedback, and have complete the role as specialists, not doing everything. So this is the core of what we are proposing. It is nothing new. We've in Mexico, in different states, this work has been done for many years, so they already know these concepts and they use them. But we want to install this model in a more global level. The sixth chapter is promotion and prevention from this perspective of transformation. The idea to have this promotion and prevention from distant perspective is within the health sector and outside of it. So the role of the health sector is to promote this work being done in other sectors like schools, prisons, refugee spaces, and on the other hand, specific work within the health sector that can be done. In this report, we prioritize three uh, we prioritize three prevention examples, which are the areas where we have developed or gather the scientific evidence to promote and be sure that it's going to have an impact. These areas are suicide prevention, children and teenagers, and mental health at work. Each one of these areas, in each of these areas, we promote a work. I apologize. I'm distracted with English. I translated the slides, but I'm using the incorrect file. But I'm going to send you the translated file uh, for those who are interested in checking. So talking about suicide prevention, the focus is to live life approach, and it promotes four basic strategies, which is limit access to means through which they can access to suicide, to interact with the media for a responsible reporting, so they communicate responsibly, also to foster social and emotional learning and early intervention of those who may have a mental condition that can end up in a suicide attempt or suicide. Regarding children and adolescents, we also promote a work together with UNICEF called HAT, Helping Adolescents Thrive, which is that helping adolescents thrive, and it's also work in schools to develop policies and laws, support to caregivers to provide a nurturing care so they can provide a nurturing care, also implement school-based programs of these policies, and also to manage and regulate the digital space, the digital environment where children and teens interact. And lastly, mental health at work, which is we recently launched guidelines, and it promotes certain actions from legislation and regulations, organizational interventions, and particularly attending the training of the managers in any workspace, public or private sector, also interventions for workers. This is something that I wanted to remove. You have 5 minutes, doctor. Okay, thank you. The last chapter is services. Regarding services, what we're doing is to promote different work with services. On one hand, health services, specialized health services regarding mental health in a communitary level, with the different levels of service available. On the other hand, mental health services in health services in the primary cares, comorbidity, and on the other side, the services that need to be outside of the mental health sector, and obviously the work of the community. The disinstitutionalization is a very important tool because budgets are in psychiatric hospitals, and we need to change in this sense. And also, when we transform, while we are doing this change, we need to have spaces for integration, self-care, like general hospitals, shared tasks, and also the work at schools, prisons, etc. Also about the mental health in a community level, a center for mental health that can offer articulate services and that in the long term will substitute the work that it was usually done in the psychiatric hospital. This is a little bit the network that we propose. On one hand, specialized services, on the other hand, general health services, and the sectors outside of the health sector. We cannot imagine a country having all of this network complete, but it is important that each country prioritize where to advance and move forward to transform the mental health sector. So we do a proposal of three changes for the transformation, which is to improve the mental health. Uh, so we need to have a better commitment in the different sectors we just mentioned to transform the sector so that is more responsible, the risk factors are limited, if not eliminated, and lastly to reinforce the mental health services so they can offer responses and answers to all the and complex needs that we can find in the different communities. Also, there's a commitment of all countries worldwide regarding the action plan regarding mental health. So we are promoting how to do this change to comply with the commitments in this health globally, WHO, and also regionally, like the Pan American Health Organization. And I apologize again of because of the slides in English, but I'm going to send you the complete version in Spanish. Thank you very much.
Muchísimas gracias, doctora Débora
Thank you
Crestel.
very much, Dr. Deborah Crestel, for introducing the World Report on Health, Mental Health, Transforming Mental Health for All. So allow me, Doctor, to tell you that we have 3,000 people connected in Zoom, but we were able to have an enrollment of more than 13.
Interesadas en el tema. Entonces, la verdad es que es un enorme gusto todo lo que nos ha compartido. Nos ha permitido
to have you with us today. It has allowed us to realize that we are doing well at the Mexican Institute of Social Security, what we are working today, also with health sector in terms of mental health. And we have 13,000 people enrolled, so very interested in your topic. So we are going to see if there are any questions from the audience. Doctor, there aren't any questions. I don't know if you would like to share any final comments, any final thoughts after your presentation. Thank you so much. Well, yes, thank you. First of all, my last name is Kestel, just to remind you, and also that it is a pleasure to know that the Institute is having progress in this sense, and hopefully it is something that at a national and federal level in Mexico could be advanced. Capabilities and capacities are there in a country such as Mexico. So hopefully they can turn into an example for others that are maybe a little bit behind in that effort of change. Personally, in my experience, having visited and known a huge amount of countries and having discussed and read about many others, I think that all of the countries today could be doing more and better for mental health of its population. And there is a tension, as I was saying before, in terms of mental health. there is an attention, and hopefully this will turn into concrete action so that those having a mental health problem can have a role as any other person in the community and can receive the care and attention that they deserve as any other person having any other type of health need. No more nor less than someone that has their arm broken, for example, in any place of our country. The same level of attention and care. If there is attention and care for those breaking an arm, there has to be the same for those having a mental health issue. This is my wish and my hope. So I will remain here for any question that you may have and for any cooperation needs that you may have. Thank you so much, doctor. And what you were just saying and what you just shared is a huge challenge. You know, it's a huge challenge transitioning to this new model. And what we would like to ask you, I mean, that since we've been working in this sense, is what are the actions that you consider to be important to promote the change management? What are the strategies that we should follow to be able to facilitate the adoption of a completely different model compared to the predominant one at a national and international level that we have today? How many hours do we have so I can address that question? It is not a simple question, but thank you so much for that. Well, I believe that there is knowledge, there is capabilities and capacity. So it is a matter to sit down, having some round tables and bring in all the different stakeholders and players and sectors so that we can start working on it and put all of our hands on it and identify priorities. My suggestion, concretely and specifically and practically, to look at this report and decide what are the priorities that at a state or federal level have to be started, or what are the priorities that are the most relevant because of any reason, and say, okay, this is a concrete plan of what we want to do. In my 30 years of experience at an international level in mental health, I've seen a huge amount of policies and programs. I don't really care about them, honestly. It is very easy to write down a plan and a policy that no one is dominate or have expertise, because it will be forgotten in a file, in a computer of some people. Yes, we need a plan, but it has to be an immediate action plan. What are we going to do in the next 2 years? Then long-term vision. But specifically, who's going to do what? I think we have to start by that and deciding that this is time to change the situation. Conditions are there. It's just a matter of deciding. And then asking for more resources, asking for different sectors, if they have something to say or to contribute, then to show how evident the need is and what the response to that evident need is. Because one of the problems that we've had historically is that we say, oh yes, mental health problems are important, but when we are asked what needs to be done specifically, concretely, then we have 50 different opinions without a concrete action or plan. So that's where we need to have coherence, and we have to align, and we have to unanimously say these are the priorities that we agree. Once we move forward, we are going to continue with others, but we all agree that we have to start with this. So those that have to support us are the authorities of any sector, so that they can have a clear and a sole opinion on how to move forward. In mental health, we have a tradition, you know, of discussing and each having their own version of the story, but that doesn't help a lot. So we need to look for agreement and common places so we can move forward. Thank you so much, Doctor. To us, it has been a pleasure to hear your presentation. Thank you so much for giving us this time. All of the sisters institutions, thank you for participating, and hopefully there will be an opportunity to discuss later on the problem with you. There's a lot to do, so thank you to you for so much. Thank you so much for inviting me, for the opportunity, and thank you so much for the 13,000 people that have registered and enrolled to today's conference. So let's see what we can do together. Thank you so much. And now we will continue with our next presentation. For this, I would like to introduce my next speaker, Dr. Juan Manuel Quijada Gaitán. Dr. Juan Manuel Quijada Gaitán is a psychiatrist by the National Institute of Psychiatry Ramón de la Fuente, and currently he is a general director of the psychiatric division at the health system. And amongst his accomplishments, he has had the coordination of multidisciplinary community attention teams, strategy implementation, and specialty services in the first level of attention. Dr. Quijada will be talking about perspective of the health general law in terms of mental health and addictions in Mexico, amendments, challenges, and institutional challenges. So, Dr. Quijada, thank you so much for sharing this presentation with us, and welcome to this International Congress on Mental Health. Thank you so much. Good morning, everyone. It is an honor. I would like to thank the Mexican Institute of Social Security, IMSS, for the invitation to participate in this second Congress of Mental Health Consolidating Alliances. And this is what we will be doing and talking today, how we've gotten here and what are the challenges that we face. On May 16, 2022, in the official Gazette, the amendment to the General Law of Health and Addiction was published. Fortunately, when it was published at the official Gazette, we already had and we still have some progress. And we are on a good we are in good way to make changes in the system. Today, I would like to share some images while I tell you a little bit about this, and it won't take long. I will talk about the evolution of mental health and addiction system in our dear Mexico. The contemporary history started in San Hipólito's Hospital, 1567, the Hospital of El Divino Salvador, and by 1910, several centuries later, we had the institution called La Castañeda. This was a psychiatric ward, and it worked with what it had at hand. By 1964, we had the Operation Plan Castañeda, where La Castañeda Psychiatric Ward is fragmented, and it gave birth to different hospitals. For example, the Fray Bernardino Alvarez Psychiatric Hospital, as well as Samuel Ramirez Moreno Psychiatric Hospital, and some other hospitals as well. This happened similarly throughout the different states of the country. And the other important change, that would be the fourth important change in the evolution of psychosocial health and addictions attention, was the reform, the amendment to mental health and addiction that I will tell you now. There is our presidency model where we are going to exclude and socially exclude and segregate, where infanticide, isolation, and begging was allowed. Here, we have La Castañeda that was reinforced with the Castañeda operation in order to eliminate certain behaviors. However, some paternalizing and normalizing activities remained. And of course, we did a protected work that favored the possibility of eliminating all these poor practices. And the psychosocial and human rights model brought inclusion and social equality, as well as reasonable adjustment, so we could have the recovery of the community. Mental health as a social problem, of course, is a social problem. That's how we look at it from the Mexican model, where the family plays a very important role, a critical role, both in favor and not in favor in sometimes. Also housing, education, health. This has to do primary care to health, where intersectorially we can address and model from there the interventions in public health, as well as in attention services surrounding this country. And let me provide some context. Today, What is our reality, a persisting reality? We are, of course, trying to change this reality. We're going through a transformation. However, synergies and systems cannot be changed overnight. And some realities persist. Up to 81% of people with a mental disorder do not receive treatment. It takes from 7 to 14 years to receive a diagnosis and receiving treatment. There is still involuntary hospitalization, a very high percentage of the cases, and we have very little bed and very little support of the third level of attention. About mental disorders and COVID-19, they were increased 25%. I'm talking about mood disorders, and the importance of mental health was visibilized at a worldwide level because it happened in many countries. On the other hand, in cases such as ours, this added to increasing the gap in attention. So if there was already a big gap, now it is bigger. The pandemic has also shown that health services in general and mental health services in particular haven't been addressed. We have an opportunity, and we have taken full advantage of this in Mexico to change paradigms. Where are we headed in terms of human rights protection? And talking about this, we have had opinions by external bodies. And I'm going to tell you how the Committee for the Rights of People with Disability has played a critical role in addressing the rights of people living with disabilities. Since 2000, human rights has documented via the report of the torture prevention mechanism, reports by the OAS, as well as other institutions of the civil society.
Institutos o
Also, some
internacionales. Lo que ha
international institutions have documented what we've already known, what we've already discussed, which is that they have been talking about what favored neglecting mental health for so many years and everything that has favored the violation of human rights in the country. We also have the International Charter of Human Rights, the Convention Against Torture and other treatments or cruel actions, and in 2006, the Convention of the Rights of People with Disabilities. This year, at the beginning, there was a report on what has been done in Mexico and the progress that we've had. We also have other technical standards, for example, Caracas Declaration that you've all heard about, talking about restructuring local systems of human rights training since 1990. And we have also been talking about the OAS Treaty, Panama Consensus, in order to eliminate stigma and provide access, equitable access to mental health, to persons with mental health. During this administration, and I would like to say hello on behalf of Dr. Jorge Alcocer Varelas, Secretary of Health, that has been the main promoter of this amendment and has undertaken the commitment of transforming mental health in this country. So what can we talk about public health? We're aiming to improve health and quality of life, reduce this gap in human rights, preventing discrimination and stigma, for socioeconomic development, favorable environments where we can have other input to our community, as the current mental health definition states. The change of paradigm means leaving behind the asylum model centered in psychiatric hospitals that enabled segregation and exclusion as well as discrimination, and focusing in a communitary model emphasis in health services. And what do we aim? Mental health and psychoactive consumption normally has been outside of the health system, and this change of paradigm is, among other things, that this new and community model allows us to address these problems from a new paradigm focused on people and communities. So why should we amend our general law on health? Because we need to favor, and that's a delay that we had in this topic, we need to favor the operative integration and leading function, something that today is unfortunately happening. And there is a leadership and we are integrating institutions. Guarantee attention of comprehensive health that's continuous on different types of diseases and comorbidities. So we can have a comprehensive care, and promoting this comprehensive care has to include the component, which is mental health, aligning the General Health Act to international standards. I was talking about the International Convention on the Rights of People with Disabilities. This is a huge progress, privileging legal capacity of people and eliminating historical stigma. Take full advantage of scarce resources and those that we have to put them at the disposition of the entire health service so that it also embraces public policies and the functioning so it can be integrated in order to reach comprehensive attention and healthcare, supporting regulation and regulatory update with a community focus. So we can implement a system with a community approach. On April 5th this year, it was approved, and on May it was published, the amendment to the chapter of mental health and addictions in the General Health Act. Due to an effort of the legislative branch, the House of Representatives, they were the ones that started this effort. Representative Miroslava Sanchez presided this effort. She was the president of the Health Commission at that time in the House of Representatives, and Tatiana Cloutier at that time also, as well as Representative Jose Luis Montes Nieves. They submitted the initial initiative to this reform, to this amendment, and then it was sent to the Senate, where we received support and a lot of work by Dr. Navarro, the governor of the state of Nayarit. And afterwards, we had Dr. Américo Villarreal, today the governor of Tamaulipas state. And last but not least, we had Senator Margarita Valtez, who has been, along with her team, the one giving the final push so that this act was published on May 16, 2022. So we consider that Mexico is leading in regulations in terms of mental health act and its amendments. Where it comes from, how it has been amendment, taking into account human rights. And now I will start talking about the main amendments. Legal capacity for the users of medical attention services. We provide legal capacity to all of those inhabiting this country, regardless of their situation. Informed consent, support decision-making when they are in clinical settings.
Esto funciona
and anticipated will. This has been happening since 2011, but today is the General Health Act talking about anticipated will. And medical emergency when talking about children and teenagers. We aim to preserve health and life and adjusting reasonably the minor, so that the minor also has a way to tell us how they feel and how they are feeling with the treatment. And because many times we take away from our youth the decision making in terms of their health. The amendment also talks about a priority in public policies with a focus in human rights, guaranteeing universal access, equitable access to medical health and to promotion and prevention of health. The recovery, which is the last purpose of the services, which is what we aim for, in any case that may happen once interventions have been applied. a community focus to break attention and care gap. Today, you know, everything goes to psychiatric care, hospitals, but via staff training and first and second level attention and care will allow us to close this gap. This has already started happening. There are states such as Chiapas, states such as the state of Mexico, where this has already happened. You have the state of Durango. In several states of the country, the first level attention already includes mental health services and hospitals with mental health services. It is important to add and to thank the Mexican Institute of Social Security that has been aligning to the amendment and has been offering the services of mental health as a first level of attention. I'm talking about health centers, family medical units, and general hospitals called HGZs. The Mexican Social Institute, IMSS in short, has started this initiative, and we would like to congratulate them and welcome them. This is for the benefit of Mexicans. The participation of external observers in terms of human rights and supervision and surveillance mechanisms. Of course, this amendment allows for an external surveillance and oversight and training programs in human rights, since this is a historical debt. An immediate response in crisis situations, immediate response team development. We are already working in some states such as Guerrero, for example, and Michoacan, where we already have immediate response teams before emerging situations. And we also want to mitigate scalability with timely attention and care so that they won't reach a crisis moment or to an unfortunate event. And of course, the reform includes suicide actions to detect, address, and prevent suicide. We also have many others. In principle is service access principles, closeness, community, damage reduction, primary attention to health. That's what this amendment allows, and we are on our way to see it happen. Fighting stereotypes and discrimination, eliminating the psychiatric model, not more psychiatric hospitals, but turning them into comprehensive hospitals. We won't close down any psychiatric institution. On the contrary, we are aiming for these hospitals, called psychiatric wards today, become comprehensive hospitals, where the user and their families can have this comprehensive attention that all of our users need. And of course, integrating to the comprehensive network on mental services provision. So we are not looking from the outside as a psychiatric hospital, but to be included in the health system so that they can operate it. Rights to mental disorder users, of course, therapeutic plans, irreversible treatments, community attention, confidentiality, and all of these parts that have been taken into account, but they were not described in the General Health Act. The hospital admitting has to be volunteer only, and being admitted is not to resolve family or social problems. This corresponds to other institutions where the health sector, of course, has important actions to do. However, it is about social health, so being admitted to a hospital, a psychiatric ward, is not a way to fix a social or a family problem. Privileging community options instead of being admitted into a hospital. And if so, it has to be in pediatric hospitals. And we have to ask for their opinion and their preferences for decision-making. Anticipated will that requires action on what treatment preference when they are not able to, and also including the denial to receive any sort of treatment. Family attention programs, the closed circle, targeting or channeling them to specific support groups. And all of these, that's fortunately already happening, such as the state of Yucatan, Quintana Roo, What are the key points to conclude and finishing this? Well, I am going to do it as a comparison. Central attention in psychiatric hospitals. The new paradigm is talking about care and attention within the comprehensive network of health services. Also, stigmatization and discrimination, which is generalized. Moving towards social participation and inclusion in equal conditions. Also, attention that ignores or violates human rights, moving towards person-focused attention based in human rights and recovery-oriented, no in shutting people or locking people down, because problems are not solved that way. In many cases, they are aggravated. Fragmented and discontinued attention that has happened until today towards the new paradigm of a comprehensive attention that's already happening in many parts of the country. This has always been, and I want to say hello to Nuria Fernandez, head of the Family Institutionalized Services Department. This is the optimum combination of mental health services. The reform of the General Health Act is in agreement not only with the International Convention of the Rights of People with Disabilities, but also the optimum combination of health services, where the basis of the pyramid is self-care via the promotion of health and prevention, and the informal and community care via communities. When they already lose health, then a mental health service aligned to communities and to the families.
O de salud mental en los hospitales generales, en servicio de salud mental comunitaria que tengamos también cercano a nuestras comunidades. Y finalmente...
Also, finally, if this escalates, which is only a low percentage and is where there's a lot of confusion, if this pyramid works from its basis like that, actually very few users and families will need the intervention of a psychiatric hospital or a specialized hospital. Which are the challenges that we have to overcome and the possible solutions since the application of this reform? As I mentioned before, first of all, and in all cases, is to have economic support to cover all these requirements. Even if the health network gives us an impulse because we occupy all health systems in a sectorial way, it is also important to have the resources and have additional resources. Also, negative perception, resistance, and the skepticism of the staff is something that some other countries have developed and are well advanced in this change of paradigm, because there's a lot of resistance in the staff, not only the mental health staff that sometimes have lost their hope, but also in the personnel of general health. Well, there's a lot of stigma that we can train and transfer knowledge and transfer capabilities to first and second level of attention. It makes us stronger to overcome this resistance, and it is a big challenge. Also to overcome the fears from coercion, that's something historical, but we need to train in human rights and jurisprudence about these coercion measurements, and to avoid crisis. This is something that is very hard to understand, but we need, as soon as the reform is implemented, we need to continue in it. Also, to modify the nominal version of the psychiatric hospital. Until now, we believe it's the only option in many cases. In many cases, it is that the psychiatric hospital needs to solve, but this is a big challenge that we need to change. To explain that the change, it won't mean less services. So as it's happening in Chiapas, that the first and second level care of attention are there. Third, and specialized hospitals may have a relief in their workload and better use of resources that need to be focused in research, training, teaching, training, human resources, and consulting, even teleconsulting to the first and second level. In the state of Chiapas, this is happening, and it's been happening that from 50 patients that were hospitalized in San Agustin Hospital, now there are 7 once this reform is implemented, and that it's been successful until now, and hopefully it's just the beginning. We hope it's an example for the whole country. They're doing it in other countries, that we can continue with this reform, also to improve the hiring of mental health staff, to develop an induction to the job about a non-traditional communitarian model to include everyone, not only the mental health staff, but all staff that is with us. I just want to finish saying that it's a great advancement. We still have challenges, but we are in the top age in our reforms. Each state is doing its implementation as according to their capabilities and their needs. There are more better doing it, like Chiapas, Michoacán, Baja California, that they have been also implemented very fast and with a lot of quality this reform to the general health law. We are very proud, but it's still not, we cannot say we won because there's still a big gap, but we are working on it to avoid it. We have a strategy to prevent addictions, a national suicide prevention program that are in accordance to this reform are being implemented in different states, and same by the PAO, it's an example to follow by other countries. We also have help with the Institute of Youth of Mexico, also in El Salvador and in Guatemala. We implemented some help and some attention groups or emotional support groups that also are from Mexico to other Latin American countries. We're very proud to be at the top and be leading this new transformation in Mexico. I send a big greeting to everyone, and let's hope a lot of people are here added to users, staff, and we hope that more people can join us because it's a big work and regarding mental health and substance abuse in this country. And this is an historical opportunity from the president and our health secretary that they have achieved the sectorization and that we can be here from IMSS, DIF, the Secretary of Health, everyone as a sector joining for one common goal and one common work that didn't happen before, not only in the public life of the country, but also this transformation for mental health and substance abuse. Thank you very much, and a big hug to everyone. Thank you to Instituto Mexicano del Seguro Social for organizing it and inviting so many people in and out of the country. Welcome. We're working together and want to collaborate for the people and all of the countries that may need the help. Have a good day. Thank you, Dr. Quijada, for your words. We are very thankful for the experience you share and this reform. There are many questions for you, and I'm going to read some of them. There's a comment from Paraguay. Good morning. We are still in diapers regarding mental health. We need to take care of the staff who takes care also. There are questions. If currently there are some strategies to fight the stigmatization and the resistance regarding the modification of this reform. Thank you. We offer our help to our brothers and sisters in Paraguay so we can support them in their own work. And hopefully we can share with them our expertise. The main obstacle globally in all projects implemented, the biggest obstacle still stigmatization. This is something we have to fight in all countries. The issue is the same. In Mexico, we've done our part through social communication, campaigns against stigma. They don't work the same in all states. However, the stigma is fought with information, pertinent information based on evidence, scientific information. This is what can help us fight stigma. This is one of the priorities in our action plan to fight against stigmatization. We're working on it. There are some programs through social communication. We're talking, hearing, I see you regarding inclusion also. This work won't finish because it's the biggest obstacle we need to overcome before thinking in moving forward. Thank you, Doctor. Another question. Basically, it says from the horizontal and community perspective where we all contribute to mental health, what is our role as educators and what experiences that can work can be identified in Latin America? And they thank and congratulate you because of your presentation. Many times we believe that we want to do from our teachers and educators, we want to make them doctors and physicians that can detect or treat even. But the only thing we can do is detect, but their role is fundamental from the mental health, more than from the psychopathology, to promote mental health, to have better tools to transfer to their alumni so they can identify their emotions or reinforce their identity to improve or strengthen the individualization of individuals, and obviously the working family system. For educators to have this tool to all their students and their parents is basic for mental health. In case they lose, in case mental health is lost, the role is to inform promptly and channel them to where they have to go. Sometimes they want to know how to identify anxiety, depression, and how to treat them. It is important, but it's more important for them to help the children and teenagers to identify their emotions and strengthen their tools, external and internal, in a social way, community level, and also as individuals, so they can overcome the daily stressors that can develop their capabilities and they can contribute to their community. This is basically the role of educators, not only in Mexico, through training, but also in Latin America and other countries, also through information and training. Okay, thank you, Dr. Quijada. We finish the session for questions. Thank you for your intervention. Thank you for sharing this perspective. Thank you for sharing your words in the second Congress. Thank you very much. Thank you, everyone. A hug for everyone. And we are making history here in Mexico regarding mental health. Thank you very much.
Buenos días a todos y todas. Continuamos.
Good morning, everyone. We will continue with the second International Congress for Mental Health. I am Lourdes Jimenez. To continue with the agenda, we're going to go to the next panel, which is the transformation of mental health services experiences in the Americas. For this first panel, in this first day of this second International Congress for Mental Health, we're going to have the participation of big speakers as Dr. Renato Nivel Sousa, Dr. Mauricio Gomez, Dr. Hugo Cohen, and the moderator will be Dr. Mario Zapata. Mario Zapata is a consultant of non-transmissible disease and mental health of the PAHO and WHO Mexico, and we're seeing him in screen. Welcome. I'm gonna give the floor now to the moderator, but I'm gonna first say a little bit background of our moderator. He has a master and PhD in management of health services by the University of Murcia, Spain, a master's in epidemiology, and he's a physician by the University of Antioquia, Colombia. Currently, he's international consultant about non-transmissible disease and mental health of the PAHO. Go ahead, Mario Zapata. You have the floor. Good morning, everyone. I cannot show my video. I would thank if you can help me to show my video. Can you hear me? Okay, just the video. Okay, there I go. Greetings from the representation of the Pan American Organization of Health in Mexico. It's an honor. It's as it was announced, we have three very special guests, Dr. Renato Ledeira Sousa, Dr. Mauricio Gomez, and Dr. Hugo Cohen, and they're going to talk about the transformation of the mental health services, the experience of the region, which is very close together with what Dr. Juan Manuel Quijada and the great effort that Mexico is doing to further mental health services integrated in the general health services so that patients really can have access and opportunity. First, I would like to introduce Renato. Oliveira Souza. He is chief of the Unit of Mental Health and Substance Use for PAHO in Washington. Dr. Oliveira is master in medical sciences in London. He has a postdoctorate in forensic psychiatry, and he's specialized in psychiatry from the University of Sao Paulo. He has a lot of experience in the region regarding mental health and also in the work that they are doing in the PAHO. So thank you for joining us, Dr. Renato, to this presentation, and I will give you the floor. Thank you very much. Thank you to the organizers, all colleagues. I'm very glad being today with you. There's a lot of, my big challenge is this presentation of the transformation after the presentation of Juan Manuel Quijada, who is a great leader in mental health, and he has projected all the development that Mexico has achieved regarding the new law and the expansion of mental health services nationally. So I'm going to share my screen. Let me see if everything is correct. Can you see my screen? Okay, I'm gonna show it on full screen. I think it's better now, correct? Perfect. Okay, we're going to talk about the transformation of mental health services. And my idea is to have with you some information about the load of mental health in the Americas, in our hemisphere, to see the resources that we use in mental health in the region, and also the impact of the pandemic, the improvements in our region, and also to share some of the initiatives that we have regionally, working together with the member states of the PAHO, and also to share some of the examples of the activities that we launched during the pandemic, using the opportunities that the pandemic brought to this sector of mental health in all of the Americas region. First of all, I would like to give you some information that I think you already know, some data we have before the pandemic, because actually the crisis of mental health that the pandemic brought to our region is not a new crisis. We were already in crisis before we started the pandemic. We already knew that 1/3 of the load in the region of the Americas was regarding mental health issues, neurological issues, substance abuse, and even suicide. A big proportion of the discapabilities, a big part of the discapabilities in this region is related to mental health issues, neurological issues, substance abuse, and suicide. So it's a great part of the disease load in our region is directly related to the mental health programs. We don't only talk about these loads, we also have information regarding some of specific problems, like, for example, Alzheimer's. We know that is the third main cause of death in our region. If we talk about the issues regarding to the use of alcohol, 8% of the population older than 15 years old has a disorder because of alcohol abuse. We are talking about disease and these disease groups, but if we see specific disease as depression and anxiety, these are second and fourth main causes of these capabilities in our region compared to all other discapability reasons. I wanted to also mention the suicide problem in our region. We have a regional rate of suicide, which is a compilation of individual rates of each country, which turns that it has increased in 70% in the last years. So it's a very important public health problem that we need to address together to fight this issue. I believe that we also need to emphasize that with this high prevalence of mental health issues, and also a big load of disease and disabilities that these disorders bring for the population, that will go well beyond these social implications, health implications like economic implications, for the implications to the development of the region actually and locally, because we know that from these 8% of the people with a severe disease like psychosis in our region have access or receive treatment. This is the information that has two sides that are very important. One is the low coverage for treatment of mental health problems in our region, and I'm showing the example of the coverage of psychosis. But also, where we have this 18% of people who receive treatment for psychosis in our region, we also have the information that only 6 countries send information about the coverage of treatment for the Atlas survey of WHO. We know during the pandemic, so it's harder to gather and send information, but it's a reality. Not only the coverage is low in our region, but also the information that we need to improve. As a region, we need to improve the information mechanisms regarding mental health so we can have more precise information and more updated information so we can move forward to avoid these gaps that we have. We also talk about the coverage of treatment, and of course, if there's a big load, if there's a increase of prevalence and low coverage, we need to understand the reasons. We do know that one of the main reasons is that the investment in mental health is very low. Only 3% of the public budget is destined to mental health in our region. And many times, in many countries, most of these very low budget is concentrated in specialized institutions like psychiatric hospitals, which most of the times are located in big cities in the countries of this region. And since these are vertical and centralized institutions, do not help to cover the needs of mental health, because to improve this coverage so that everyone has access to treatment, the treatment needs to be as close as possible to their communities and their homes. So the low budget and the decentralization of these specialized institutions do not help the region to move forward regarding the coverage, the access of mental health treatments. And actually, many of these institutions, many of the colleagues already mentioned, these institutions are unfortunately, the conditions, the quality of the treatments is very low, and it doesn't agree with the dignity of human rights of the patients. And we do know, when we compare the data from our region with other regions of WHO, we are the region with the biggest proportion of persons who live more than 5 years in a psychiatric institution. And clearly we know that we do not need 5 years to treat mental disorders. So this is a big problem, not only for mental health in the region, but also a social problem and a very severe human rights issue that hopefully together we will improve in the next years, with the priority of knowing that the countries need to address this specifically mental health sector. We also know that the pandemic doesn't help regarding the prevalence of mental disorders. We know that this prevalence of mental disorders as depression and anxiety increased during the pandemic. We know that this increase was mainly in some specific groups, the most vulnerable groups of the population, like the first care workers that were exposed to stress and all the difficulties regarding their job, and also the deaths related to pandemic, also ethnic and minorities and people with pre-existing issues. They also suffer some affections of their mental health during the pandemic because of different causes. One of them is what I'm showing here right now. This is the result of a survey of the WHO. It was a questionnaire sent to all countries to map how health services, essential health services were during the pandemic. And we saw that in one of these specific surveys, we already did it 3 times. We're doing it a 4th round to compare with the previous surveys. And some of these surveys, the services that suffered more disruption during the pandemic was mental health services.
Ahora, con la alta prevalencia, con la alta carga, en el momento que más necesitaba, que las poblaciones más necesitábamos de cuidado.
When we needed care the most, then services didn't work. And this is for several reasons. People that working in mental health services were transferred. Other times people didn't have access to mental health services. But as a consequence, there was a moment where people needed these services the most and they were not available. So since the pandemic started, we at PAHO did a very important job integrating mental health in the response of the organization before the pandemic, in the joint work that it has been done from and along with countries to improve care, to prevent COVID diseases. So mental health from the beginning was a comprehensive component of the Pan American Health Organization. But from the beginning, it was very important to prioritize areas that we thought that could be developed along with the country's work. In one of the main areas that we thought that was going to be one of the most important ones was helping countries create coordination mechanisms for mental health on those integrated in the response to an emergency. And with all these jobs, we can confirm that most of the states prioritize mental health along with disciplinary ones, and many activities were launched for this. For example, the service rendering on health on mental health was provided for telemedicine services. We help those countries create those telemedicine services with professional education and training, also supporting some countries in terms of technical materials and technological materials to be able to do their telemedicine activities in mental health. And I think that an important aspect of our job, along with countries in the last almost 3 years, was escalating or cheering the development of capabilities of mental health training. So we created many training courses in the public health service. In the Pan American Health, in the PAHO, many of these trainings were implemented along with the countries and mainly in educators that could tier in their own countries, not only preserving mental health services, but also in order to tier and increase the access to mental health treatment. And in order to emphasize the importance of mental health during the pandemic, we have worked a lot in mental health communication. We did campaigns and we also did activities in social media so that we could have the professional health services receiving larger visibility in mental health during the pandemic in our region.
Hicimos otro trabajo, que es el trabajo junto con los ministerios de salud de los países.
Pero we also work with the ministries of our countries, but there's a work that's being done at the highest level of the PAHO.
Para lanzar una nueva política de salud mental para la región de las Américas. Para ustedes que trabajan más cerca de nosotros, probablemente tenían la información que
Of course, those working with us had information on mental health that was expired 2 years ago. Many of the SDGs were met, of the goals were met. There are important progress that are still necessary, but what we did was taking full advantage of the visibility that the pandemic has brought and the importance that many of the governments of the region already gave in mental health in their countries, was launching a new policy, a policy that closed a vision on what the pandemic and how it is impacting in the social health and what are the most important areas that we need to further develop in our region. I would like to invite all of you to look at the new mental health policy by PAHO for the Americas. I think that it could help a lot countries decide priorities to move forward in mental health at a country level. In order to give you a summary of the new mental health policy for the Americas, where there are 5 strategic lines, I think that it would be important to emphasize 3 lines that are priorities. And I think that these are priorities for all of the countries of our region. We know about the differences between countries. We know about the differences between sub-regions in the Americas, but we believe that the problem of coverage and treatment access is a regional problem. Countries that are poorer or richest need to invest in increasing coverage for treatment support. Now, the regional rate in suicides, as I mentioned before, also has increased in the last couple of years. There are countries where the rate hasn't suffered a significant increase. However, there are sub-regions, for example, the Caribbean, in the South Cone, and there are countries where the rate
sufre un aumento importante en los últimos años. Y junto con esto también, los países como los Estados Unidos y Canadá también sufren un aumento importante en las
And in Canada, in the US, there is also an increase in suicide rates. So from a regional standpoint, we perceive that the suicide rate increases in a more prominent way for women in our region. So I think that this is another great regional priority that we need to work on in a public health perspective. And it is not only moving on in terms of coverage. We have evidence of public health activities, strategies that could help us lower our suicide rates in the different countries throughout our region. And this is a regional priority of public health. Now, the third area is also featuring a new policy, and this is not only a new area. Our region launched the Caracas Declaration more than 30 years ago, but our region continues with an important problem of human rights violations, mainly in persons living in long-term institutions or facilities. I think this is a third priority that the policy has brought us, and we need to work together strongly in order to change the situation of human rights and mental health in our region. I've already mentioned the policies of human health throughout the region that have been approved by all of the countries in the Americas. But to promote this policy and to add more strength and visibility to the transformations that we expect to have in mental health in the Americas, then PAHO director launched the high-level PAHO Commission on Mental Health and COVID-19. We have 17 commissioners that are authorities in different regions throughout our country, not only in mental health. The presidents of the commission are Ambassador Nestor Mendez, Joint Secretary of the OAS, and former Vice President of Costa Rica, Madam Epsi Campbell, and they are not technicians in mental health, because the proposal by the Commission on Mental Health is to advance it in the Americas, but also advance it in a comprehensive way with the concept of human health in all policies. That mental health is not only ours, a specific area for us, nor for health professionals. What is important for all of us to have a knowledge on how mental health affects different fields of the social and economic development environments. And this is why mental health needs to be integrated way more beyond only health and mental health. And I think this is one of the main goals of the high-level commission at PAHO on mental health and COVID-19, and hopefully the report of the commission and its recommendations on how to move forward in the Americas is probably launched during the next months next year. I wanted to share with you other activities that we launched looking at the objectives and priorities that we just described for you. We have Paola. Paola is a digital health assistant where people could have access. She's located in PAHO webpage, and people can ask questions on anything, And Paola is scheduled to answer those questions with the most updated evidence existing on the prejudice. And we invite you also to get to know Paola and interact with her at the webpage of PAHO. Along with this, and we know about the important problem that people with mental health problems suffer in terms of stigma. We have a great campaign to fight stigma in the region with different materials, videos, influencers, a lot of material in social media in order to help people reflect on the stigma existing surrounding mental health problems and how stigma is still an important obstacle for treatment access throughout the region hospitals. I couldn't conclude before once again emphasizing the importance of mental health funding, because the different problems that we've shared with you are directly related to a low priority in mental health, and how this low priority causes low investment and funding. So in order to have some progress, we need to increase priority. But if priority increases, then we have more investment. So we can move forward with mental health in our region. And there are different important ways to do it. I have many examples for you. We have Chile's example, when there was a presidential initiative where the different ministries worked together in order to move forward in mental health, and where budget has been significantly increased to go beyond. The same way, we have Trinidad and Tobago experience where we have multi-sectorial committee, when we have an online platform launched too, as well as Chile, by health professionals that are connected online via internet or telephone. But there is also an important mental health training effort done throughout different regional authorities. But there are other examples, and probably I won't have time to share all of them with you, so I won't. Thank you so much once again for inviting me to participate, and hopefully we can work together in transforming mental health so we can see a mental health care that we want to see in the Americas. Thank you so much for your attention. Thank you so much, Dr. Renato. So could you please stay on the line if there are any questions or comments at the end of this panel? Dr. Renato talked about a mental health burden, and especially about mental disorders turning to the first causes for disability around the world. There's low coverage in treatment, and he also highlighted the importance of health systems to make decisions with the information that requires priority. 3% of public spending in the Americas is what countries have in average, and a huge percentage is targeted to psychiatric hospitals with a still serious situation because of the long stays affecting human rights and the right to a dignified life. A priority that he established for the Americas is the integration of mental health in response to COVID pandemic. This has been very useful to visualize the problem that people with mental problems face. And he also talked about how the effort has been happening to improve policies, hence improving mental health throughout the region via an important strategy, which is having the high-level commission of PAHO involved on mental health and COVID-19 to have some progress in that region. Now I would like to introduce Dr. Hugo Arnaldo Cohen. Dr. Hugo Arnaldo Cohen is member of the Advising Council of the International Mental Health Collaborating Network. He's a member of the regional team of mental health for disasters in PAHO from 2000 until today. He also teaches, he is a teacher in public health and health issues in Granada, Spain University. He has a master's in psychiatrics by the University of Buenos Aires in Argentina. Dr. Hugo Arnaldo, welcome. The floor is all yours. Thank you very much. Thank you so much for that kind introduction. So you can all hear me well, right? Yes, correct. So I'm going to share a PowerPoint. And I would like to, first of all, thank the organizers, congratulate the organizers for this initiative and for the repercussions that it has had, all positive. To me, it has been quite moving to see colleagues, even if it is at a distance, with colleagues that I worked with for 20 years ago. Because for 4 years, I've been a consultant in mental health in PAHO, as well as in Mexico. And we had the opportunity to share with different valuable people some great moments. And Because of the time I have, I cannot mention each of them, and I don't want to leave anyone out. But thank you so much for the work and for the affection that you've always given me. I would also like to thank the colleagues that I'm sharing this panel with, Dr. Zapata, Dr. Renato, and our Chilean colleagues, Dr. Mauricio, all dear friends and colleagues. So the presentation that I am trying to share with you, just a moment, please. I don't know if you see my presentation now. No, it is still uploading. We should wait a couple of seconds, please. Okay, so let's wait a couple of seconds. It takes long at times, or maybe I am having technical difficulties, I don't know.
No, no aparece.
No, I don't think my presentation is showing. No, not yet, doctor. Well, if it's okay with you, unfortunately, I will have to send it to you so you can have access to it. I think that the best, because of the time we have, is to continue, if it's okay with you.
Mi presentación sin que la puedan leer.
Do you agree if I start? Oh, we already see it. I think we already see it. Oh, great, perfect. So, let's move forward. So we have the first one. Will you have it there on screen? Let me see if I can share my full screen.
Aquí está. Bueno, gracias. La tecnología, entonces.
Technology, you know, well. So I am going to talk about the different components. Now, Dr. Kester and Dr. Renato, my dear colleagues, have already mentioned some components, but I will emphasize on some specific aspects. Now, COVID, we cannot start a conversation on mental health without mentioning COVID. It has already been done. Isolation, job loss, fear have generated the increase of depression, anxiety, insomnia, or suicidal thoughts. Alcohol and other drugs consumption has also increased, and paradoxically, those with this problem also are more prone to suffer from COVID. Now, trusting authorities and being heard, having with protection materials, perceiving dignified, paid, being part of decisions, work planification, and preventing overload are key factors for protecting mental health in mental health daily life workers, ourselves, because it has been the most affected sector and the one that is presenting the most problems. I am going to emphasize on de-institutionalizing or making people leave psychiatric wards. And it is important to know what this is. But for this, we have to understand what it isn't. So what does deinstitutionalizing means. It is not leaving people to their own resources, to their own devices if they have mental problems. It is not taking full advantage of economic, physical spaces or selling land for psychiatric hospitals. It is not reducing the hospital beds without including alternative responses for the treatment and rehabilitation, because this would be another attack. It is not only a psychiatric support. It is not reducing the number of beds without creating treatment and rehabilitation alternatives. And it is not leaving people without a job, because the law, and let me congratulate you, the law in your country, it has sanctioned recently already. It is not leaving people without a job. If we go back to the data that Dr. Renato shared, and I'm sure they are the right ones, as these services are developed nearby where people live, definitely then we would have to significantly increase demand, hence work, hence the need for human resources. One of the axes that are the basis of deinstitutionalizing in the International Convention of the Rights on the Rights of People with Disability, which has already been mentioned a moment ago by Dr. Quijada, every person is capable until otherwise proven. And the concept of being the society that makes you disabled. We could all agree that this is the way it happens. But when you analyze this in practice, it actually means an impact in the professional identity, in this case ours, and our psychiatric identity, that I'm going to describe. When I went to school, when I studied psychiatrics in Buenos Aires, when you were asked in the test, what's early dementia or schizophrenia? Well, it is a chronic dangerous disorder. It is a progressive deterioration, impairment, and you cannot recover. If you answered those 4 categories, you were told, great, you passed, you have an A. 40 years later, if you say that, you are failed. You are failed because there's a series of social and scientific and technical and field progress, field and human rights field, that have transformed the clinical concept, fundamentally the clinical concept, because now this otherwise dangerous progressive impairment, etc., is capable until proven otherwise. In other words, those theories called, for example, schizophrenia theory, today they can get married, they can have children, they can go to school, they can buy, they can work, they can sell, they can vote, the same rights as any other citizen. Then this means a huge earthquake to our professional identity, because we've learned otherwise, something different. And today we have to relearn and update our information to adequate this, to align it to these new commitments. I am going to give you another example. If someone has a car accident and both legs have to be amputated, then according to the convention, it is not a fundamental aspect having to do with the lack of legs being disabled, but if the state is providing a wheelchair transportation, having access to public transportation, if there are special restrooms in public spaces, if they have a wheelchair, as I already mentioned, etc., etc. In the same way, if there is a vision impaired person, the diagnostic of blindness is not the core, but if they have Braille reading, to be able to use and Braille training to incorporate it to their daily life in community. So everything required for their inclusion. This is the dimension that mental health evolves in today. What should be the support and the needs that have to be covered so that this person otherwise irrecoverable, can keep a dignified life and included in the community. What are the characteristics that these services should have in order to see what are the needs that we have? Well, accessibility and continuity in care. Accessibility means that we need to have the population out in reach, both geographically and physically. And Dr. Renato said it, people, and it is proven that the closer they are to where the person lives and they can have access to the service, then the better possibility to recover and better prognosis they will have. And care continuity is the need to have services and devices that make this possible. So it is not only that you have been discharged, come back in 15 days, no, but providing everything that they need, as we already said, so that this person is effectively included in the community.
Estructuras intermedias, seguimiento domiciliario, internación domiciliaria, hospital de día, camas en hospitales generales, hospital...
General hospital, beds in the general hospitals, sites to educate families, among others. For example, a person who has diabetes or hypertension, they will only receive the registration. They will never recover completely. Treatment will include to do follow-up so he can use insulin. And insulin should be a first level tool and then transcends in hospitalization. It's something that has to do daily for the rest of his life with his family and their services. It's also necessary to support family, neighbors, work colleagues, teachers, religious people, the police department, and give different characteristics of the services that need to be developed to bring these right. Is that primary mental health treatment is only possible if there's a permanent support from the second level. So training on mental health is not a vaccine training that is short, it's just 2 weeks, and then 6 months later we do a refresh. Here it has to be continuous. We need to have a permanent follow-up and support plan to the staff, the main care staff. This is why it is more important to identify the first level care and see the second level giving this support and this counseling, or however the country wants to call it. So there are different components for the organization of the services with accessibility and continuity. I mentioned already some aspects. There are some matters that have to do with the frameworks like protocols and standardization, law. Everything that has to do with commitment was already mentioned. For example, the increase of the budget and financing, and also the competences that has to do with capabilities, sensibilization of the community, formation for professionals, everything that has to do with knowledge of this new paradigm. And that's what I'm going to talk about. During my 4 years working together with you in Mexico, I was part of a report, part of this Congress in 24. You can find it on internet. Dr. Quijada also mentioned it. And there I mentioned many aspects that I believe may be current still today. Law. A law is important, is not the starting point nor the goal. It's a part of the process. It has to be part of this. And the important is that law and policies need to be complemented. In Argentina, we have since 2010 mental health national law. However, even with this law, the developments, the concrete developments in this sector are not so much. The law hasn't been able to express in this visible transformation that actually solve the needs of the people. Law is effective when the needs, the concrete needs of the individuals are satisfied. Not because we have the law, there's a solution. In Rio Negro, where I was chief for 15 years, it's interesting to know what Mario Testa showed us, that this law from Rio Negro came after the practice, and the law legalized what the practice had already standardized. It proved that that was the path to follow. With the competencies focus, there's a conception, the biopsychosocial, that we also mentioned simply, but it's not as simple when becoming a practice. So when we see how we work generally in different institutions in the regions, there's not such interaction. It's hard of these have interdisciplinary groups, and we think we need to prioritize this in this moment of new knowledge. Some of the aspects is that the budget needs to follow the individual instead of the bed. The bed could be only a moment, but afterwards, there needs to be a follow-up. So we require to have the corresponding budget, and the challenge, not only to have the people included in their community for every day. The challenge is to have this individual to be included in the community, and not only the 10 days of hospitalization. So we've learned and we've proved that this is what works. Not the hospitalization, but what happens the rest of the time. We've assisted many cases, visits in institutions where the directors were very proud in reducing the number of beds. But when we ask, what do we know about all of those people who left those beds? There was complete silence. So the important thing is to do the follow-up of these individuals. Regarding this and the pyramid that we have, this gives more a level of complexity, which requires more resources. This is not the third level of mental health. The ones that requires more intelligence and resources is the level of the community. Hospitalization is only in specific cases and is relative to the network services. In many countries, they don't have available, they have only these available once the person left the institution. So this continuity, this rehab, effective rehabilitation is not done, and they don't have answers of who's doing it. And also, to be close to the daily context of the person gives more possibility of having better evolution. 1 second, my slides are frozen.
No, no hay caso. Se quedó acá.
It's not working, it froze. Okay, there you go. To update the training of specialists and health professionals in the new framework. We already mentioned what happened with those physicians regarding early dementia, and once all the technical transformations came, what happened? Another component, something that we see immediately, we see what they're doing, like Brazil, Chile, Argentina, but let's see the quantity of professionals. Argentina has 13 psychiatrists and 130 psychologists for every. I think in Mexico there are 1.5. So imagine 10, 100 times more. Dramatically, if one studies the population that don't receive any type of attention is not that different, the one in Mexico and the one in Argentina. So the quality of professionals is more important to talk about the numbers of professionals and to see how they are trained to work in which mental health system and for which services. This is a course we're giving in the whole region, actually to colleagues from Mexico have done it, and I send my greetings to Dr. Clarissa, which is mental health legalization and human rights. This is how we make a law effective, how we apply it in the practice. Because we know that talking about it and doing it in daily practice, there's a world of difference. And that's what we pretend to help to solve. We, for example, see in the physician, in the medicine school, with students from Bolivia, Chile, Paraguay, Peru, Ecuador, Mexico, and Argentina. And in March, they are invited to the next round. So all of these transformations require political decision, a change of attitude of the professionals, and empowerment of users and their families, which are also experts, because their experience, only because they lived it, they are experts and they should be included as such. The process in Rio Negro can be taken as work to learn from mistakes. Also, they achieve good practices, and as a consequence, they include the new services. So mental health was the 5th basic clinic. So in any hospital where the 4th basic clinics are surgery, medicine, pediatricians, and also gynecologists, they should have the same status and budget as mental health. If there's a bed for surgery, there should be a bed for a mental health issue. In Rio Negro, they could close the only psychiatric hospital after 4 years, but it was a finding actually during the development of those practices, because it is important for you to know when mentioning this paradigm, the stigmatization, we realize that as much as we humanize a psychiatric hospital, since it's a cultural phenomenon, we need to transform. The patients would become as a madhouse, let's say, and this would make the change of stigma very difficult. So that's why we decided to close it. What took longer was to the transition, so that every municipality state is in charge to also take care of mental health issues. Also, it also needs to respect the particularities, the local particularities, and the general principle, which is the law you see. This is other of the things we've learned, the importance of talking with a simple language to do what we say, and also so that our own bags can be transformed in the substitute of the law. I'm not going to mention the content of the law. You can look for it on the internet. This is the first law of Argentina in the American region, and it was the background and the basis for the law 26657 that before 2010, 20 years later now, is now the national Argentinian law for mental health. One of the tools that is forbidden the application of the electrotherapy is included in the rules of law, and the other was in Geneva, Switzerland. And it's interesting to mention that when applying these, we haven't produced the episodes that were to prevent this electrotherapy as it was taught to us. Also, these slow changes that the crisis and the increase of poverty and inequalities made us to look for new ways of containing the crisis, which is an increase in complex problematics. This situation was expressed also in the institutions, a difficulty to integrate the addictions not related to alcohol, and the new professionals were lacking the adequate training. So there was an imbalance between the academy and the practice, the law, and the international agreements and conventions we're trying to solve. So we need to put it at the same level. We learned that the politics are built and need to be reestablished, including all stakeholders. So it's not something that it happens once and works forever. It requires a work with a good leadership. It has components that are very true, like, for example, passion, affection, fighting, and uncertainty. Some of the resistances and difficulties we find, the need of time to validate the recognition of society. You can say there's law, there's a convention, but people, neighbors, when you want to build a transit home, they're gonna block the street and everything, and they want to ask you to remove those people from there because they're dangerous, they can rape, we have children, and that's even before questioning. Let's understand that that's the existing culture right now that we need to modify. So that's why, as much as we can, proving with facts that actually these people is not as dangerous or a raper, they can even collaborate in the community work. That's when acceptation will come and this paradigm change will come. And within time, the same population that were claiming to remove those mental health patients, they are the ones who are going to claim that they don't want to remove that home for mental health patients. So that's the process we need to build. There was an attempt to modify the law, but none worked. And what we do claim is to give resources that the law says, and that we still don't have, or we still require. I've taken some slides of Elizabeth Bruñón, which is the current director of Rio Negro. These are 260,000 square kilometers, I think. The black squares are the cities. The current population should be 800 inhabitants. So it's very low, but there's a big dispersion. So to give coverage was the challenge. I think that currently there are around 38 general hospitals. And how interesting this is. When we started the work, we were 65 in the whole province. 90% was in psychiatric hospital, as it usually happens in most systems. They focus the resources and they don't solve the problems as they should. From 64 in 2021, it reached 324. It wasn't losing the job. And if we focus the energy, we had to increase the number of professionals. But the difference is that now the composition changed, the training changed, the services changed where these professionals work. And what I wanted to point out is that from the total of 324, 139 psychologists, 102 operators, 37 psychiatrists, 15 social workers, 7 administration, and there are no nurses because the nurses are the general nurses trained and they can do their work also with mental health patients. So a mental health operator are persons of the community, sometimes not even with elementary school finish. They are trained to give services and they are paid for their services and they connect the community. These are neighbors. They are the ones who 3 days ago, this patient didn't sleep. They have a music very high or just walking around, and they can go to the team and tell us, and we go. This is one of the most frequent actions, the follow-up and visit their homes. So they have the daily dimension. And in Mexico, you say you have low professionals. You can train a lot of operators. It could be even only regular common people, and they do a great homework when doing the follow-up. I'm not going to mention all of these. These all centers, help centers, etc. This is part of what we need to develop. So in 1985, almost 200 crises were attended with internet hospitalization, and in 2002, it's been almost 1,600. So it multiplied by 15 the amount of crisis intervention. And it is not related to the increase of problems, but an improvement of the coverage, because now services, most of general hospitals have mental health services with all the benefits that we just mentioned, hospitalization, follow-up, and main care. This grew from 11,000 to more than 160,000. And other data as the number of increases attended, as the number of increases attended increased, the days for hospitalization decreased. So the time for hospitalization decreased in the hospitalization days, and this means improvements. The last slide, these are the recommendations, the desinstitutionalization, the law. These are recommendations based on community, of who establishes for the world. There is result of the compliance of the states and based on scientific evidence or as legal and social evidence. Some of the countries that are working on this are Chile, Brazil, Peru, Panama, etc. Thank you very much. Thank you, Dr. Cohen. As he has pointed out, he showed what disinstitution is not, to have an adequate health care for mental health patients. He also talked about their rights and the need so that mental health patients or people with mental disorders preserve their rights, the conditions that of the healthcare that need to be reinforced. And also he pointed out something very important, that the main care of mental health needs permanent support of specialized second level. Law is not the objective nor the starting point. It's just actions to ensure the effective care. And he also mentioned that the biosocial, psychosocial focus is necessary to work on it, so there is not only hospitalization, but also to complement during the rest of the agenda of these patients. They also talk about the weakness of human talent regarding training, and it's not only about how many physicians or nurses or operators we need, but it's more important to focus the conversation on the quality, so that this care is effective. Thank you very much, Dr. Cohen. Also, thank you, Renato Oliveira, who had to leave. So we conclude the panel of this transformation of the services of mental health in the Americas. Thank you, Dr. Cohen, and thank you, everyone. Thank you.
Muchísimas gracias. Y con esa...
Thank you very much. And now we are going to close the first panel of this morning, Transforming Mental Health Services Experience of the Americas. Special thanks to Renato Oliveira Souza, to the moderator Mario Zapata, and Dr. Hugo Cohen. Now we're going to continue with our program of our first day of the Second Congress of Mental Health, to continue with a debate called Analysis about the Regulation of Cannabis Use. For this debate, we're going to have as a moderator, Dr. Gary Savitsky-Surratt, National Commissioner Against Addictions in Mexico. And also, he's going to introduce the speakers from Uruguay and Colombia. Dr. Gary, welcome to this debate. Welcome to the Inter-American Conference of Social Security. Our moderator has a master's in medical science and marijuana for health from UNAM in Mexico. He's also a surgeon with specializing in psychiatrist by UNAM and the Ramón de la Fuente Institute. As I mentioned, he is a National Commissioner Against Addictions in Mexico. He is a professor of addictology in UNAM, professor of Masters of Public Health in UNAM, and he also worked studying genetics in addictions and maintenance systems with methadone in Rockefeller University in New York. Welcome again, Doctor, and I'll give you the floor to moderate this debate analysis about the regularization of use of cannabis. Thank you very much, colleagues, everyone who's here in this place. I wasn't able to be here in CIS, and it's very pleasing to see We Can Smell Academy and intellectual activities. And I'm really, really grateful for the opportunity of the Executive Federal and the Health Secretary to be part of such a big event. I think it's actually going outside of our expectation. And I was invited to participate about the legalization of cannabis. It's a subject that I particularly have been working on for many time. It's very close to my heart. It has a lot of aspects regarding culture, human rights, legalization, medicine, counterculture. And today we're going to have a very interesting panel. I've just if you see the global earth from Argentina to Gibraltar, the cannabis regularization has moved on a lot regarding aspects of human rights and also cannabis medicine, which is a very interesting area of opportunity we just found in this new 21st century. And we have representative of two emblematic countries. On one hand, we have Dr. Juan Manuel Orjuela Rojas. He is from Colombia. We are also going to see some data of their formation, but he represents a big Latin American nation, Colombia. We've had a lot of work together with them. I personally respect them a lot, my brothers in Colombia. And why not to say that the new President Petro starts and predicts positive times in this future of new changes, new ways of thinking about things. So briefly, just Dr. Juan Manuel Orjuela Rojas got his diplomat based on evidence in the National University from Colombia. He has gone through many courses in Colorado Boulder and the Tecnológico de Monterrey. He also is specialized in neuropsychiatry by UNAM, and he's a psychiatry specialist by the University of Bogota in Colombia. He also has an academic history. He has been teaching in the Cannabis Diplomat in Amsterdam Institute. He also gave conferences in different events in Colombia and countries like Mexico, Peru, Uruguay, and Argentina. And he's member of the Psychiatry Commission of Psychiatrists and Neuropsychiatrists of ACP. Currently, he's a neuropsychiatrist from the Colombian Association of Neuropsychiatrists. So thank you very much, Dr. Juan Manuel. I will give you the floor to listen what you have to share from South America, Colombia. Thank you for your participation.
Hola Gaby y a todos los asistentes, muchísimas gracias por esta invitación.
Hello, Gabby and everyone. Thank you so much for the invitation. I feel so comfortable and I am so appreciative of the invitation to see so many people connected. Thank you so much for allowing me to share my expertise as a neuropsychiatrist, cannabis-wise. It is so interesting because it has given me an atypical opportunity. Let me tell you very briefly, I had a preceptorship in Canada in 2019 with the Sante Cannabis Clinic, where I was participating there with the clinicians, with patients. And as of 2019, I came to Colombia with this knowledge, and I have been working in the use of cannabinoids for mental health. So I'm going to very briefly share my presentation. It's going to last like 15 minutes. Please let me know if you can see my screen. So I'm going to talk about my experience in terms of the use of medicinal cannabis. And we can start a debate later on in terms of the use for adults. And most of us in psychiatrics or psychology, we relate it to mental health. And we've learned that cannabis actually it was toxic for the brain. And this could be true, and that's why I'm here on the left part of the slide when they said, if you take marijuana, there is a certain risk to suffer schizophrenia, a mental disease, which is true. A person that's 15-year-old and starts taking THC frequently at a high dosage, in a brain that's in neurodevelopment, in a brain where frontal regions haven't been myelinized, then it is a higher risk of psychotic crisis and schizophrenia. So here we have causality versus association, but also cognitive alterations are evident in this population, which is young adults, and that's consuming THC at a high dosage frequently. This is what most of us were taught, that was toxic, that was bad. However, on the other side of the slide, we could say, well, but with the arrival of the endocannabinoid system and the discoveries during the 90s of CD1, CD2, and all of the cannabinoid system, we understand that also mental health is associated to this system, perception of pain, anxiety, sleep regulation, appetite. So we started seeing a series of very interesting researches on the use of cannabinoids in mental health. So this has put us in this surrounding when, is it toxic or not? Is it bad or good? What is the position that we have in terms of cannabis? But we also did another research published last year. This is the paper where we elaborated on the knowledge, the beliefs, and the attitudes of Colombian psychiatrists, which is a sample that also shows the Latin American thought. I was able to travel, as Gabi said, in congresses on Paraguay, Argentina, Sweden, Costa Rica, and the perception is the same, that most of the psychiatrists respond this type of questions, which is what we published. I support the use of medicinal cannabis in patients with cancer, epilepsy, chronic diseases. Most of them agree. But when psychiatrists were asked if they would support the use of cannabis for schizophrenia, no, not at all. And we are going to see that cannabidiol, for example, could have certain antipsychotic effects in schizophrenia. In depression, no use of cannabis, post-traumatic stress, kind of. But basically, in all of mental disorders, psychiatrists disagree. But why do we disagree? Because we haven't interrelated the endocannabinoid system and the beneficial points that some molecules such as cannabidiol could give us, or even low dosages of THC, as we will show later on for post-traumatic stress disorder, for example. The experience that I want to share with you has to do with two fundamental aspects in terms of the physician, which is the prescriber, and the legislation and the regulation, because there are also some regulatory panels too. So how should cannabis be regulated? This also has to do the evidence saying, I am not going to approve cannabis products that are for hair loss or for acne or for overweight, because there's no evidence. And this is very important, because many pharmaceutical companies and many people interested in selling products with cannabis are generating an amount of evidence that's false or preclinical. For example, we have memory. Could you please close your microphones? There is an open mic. Thank you. There is also something important in terms of regulation, the quality of products, because we know that products could be contaminated with fungus, bacteria, as I will show later on. So very briefly, I'd like to show the evidence. This is a presentation that lasts an hour, but I'm going to summarize it. The use of cannabinoid is useful in mental health. Here we have Jose Cripta's clinical trials with Sao Paulo University, and they have done many researches about the anxiolytic effect that cannabidiol has in people with social stress disorder, people that's afraid of public speaking, people that become tachycardial or that start seeing a rash, that had tremors. This is social anxiety stress. This population is always vulnerable to this type of events because they generate anxiety. The group of Dr. Kripa, for example, is one of the many trials that we have out there. But in this one, for example, they share cannabidiol dosages from 100 to 100 milligrams, where basically they are managed in different stages of the scale. So we have previous stages, previous to speaking. For example, when I tell you you have 3 minutes so that you start speaking, This participatory anxiety in this previous stage can take it, and you see how anxiety increases here. During the speaking, the person is quite anxious, so there is an increase in this analog scale of anxiety. However, when we compare these to cannabidiol 100 to 100, the 300 milligram dosage has proven in different trials that could be of benefit to treat symptoms of social anxiety. And it is also proven here in another graph where there is an evidence that is corresponding or arguing that we can use it in this population in 200 milligrams. I'm also going to show you the post-traumatic stress data very quickly. But people with PTSD are people that has had an incident that could be vital, for example, a car crash, burglary, survival, ICU stay. They start having flashbacks, nightmares, intrusive memories, hypervigilance. The endocannabinoid system regulates all of these memories via their influence that they have in the brain amygdala. So Dr. Lucas Elms has a series of cases in the US where he administers cannabidiol 50 milligrams a day, and this follows the PCL5 score at 8 and at 4 weeks, and there's evidently a symptomatic reduction, always using cannabidiol as a coadjuvant. This means that the patient is receiving medication and they incorporate cannabidiol to potentiate the anxiolytic effect. We never act as a monotherapy or as a first time. It's part of the evidence. Another one is, for example, at the group of Rafael Meshulam in Israel. You know that Meshulam is the father of medicinal cannabidiol. He was the one that isolated the THC during the 60s. And he has a group of investigation of research, very solid one that administers low dosages of THC, which is quite a controversy, but we have the possibility of administering CBD-rich and also others that are rich in THC and also combinations with low THC in Canada and other countries. So studies like this was where they administer low dosages of THC, 5 milligrams every 12 hours, found very significant improvement in the PTSD scores. Even in nightmares, there is a very significant reduction in nightmares. So they're starting to have more evidence. Insomnia-wise, for example, almost always the trials, this one by Shannon, shows once again that insomnia could be treated gradually in refractory patients with cannabis, especially when they have anxiety symptoms, because as we saw, cannabidiol is anxiolytic. Being anxiolytic, it lowers the density and the person can sleep better. This is why in the study they compare the Hamilton scale with Pittsburgh scale. The Hamilton is an anxiety and Pittsburgh is a sleep scale. And look how in months it reduces symptomatology. So anxiety goes down and sleep improves. We can discuss it later on, but I'm showing you here that there has been research, quality research, and are not that small, 47, 95. There are others cases, and there are also trials that are a little bit larger. And this is a very interesting one for discussion, which is the use of cannabidiol published in Lancet Psychiatry in 2020. The use of cannabidiol for the treatment of cannabis use disorder. So a person that has a dependency to THC, that consistently smokes, that cannot study, that cannot work, that cannot have family stability, the use of cannabidiol to higher dosages, 400 and 800 milligrams, proved in that study a reduction in the consumption measurable in urine, but also in the days where they didn't receive THC, which is called abstinence days. It was way greater than in patients with 400, 800 compared to placebo. So this means that, and I show you this because there's always a matter of cannabis creating dependency. Cannabis is harmful for mental health, but I'm giving you a very quick sweep of the studies that show the use of cannabinoids in mental health. I didn't bring the ones for autism. We also have those. Schizophrenia, we also have those, but especially these have a methodology that could be interesting. And last but not least, I would like to show you what would happen long-term, which is a debate. If we don't regulate, if we don't know long-term, then we have studies in 2016. There's one that was in the United Kingdom, in Germany, in Switzerland, that shows that patients using products having CBD and THC, also products one-to-one, like nabiximols, had 6 and 12 years had a very low psychiatric disorder incidence. So in patients that had chronic pain, followed by multiple sclerosis. But for example, depression rate was 0.0014, anxiety 0.0023, and also the greatest fear of psychiatrists with THC is producing psychosis, which, yes, it happens in teenagers that take it frequently, or those having genetic particularities because of THC consumption. And those studies in taking low dosages of THC in 6 and 12 years had a very low psychotic events, 0.025, also suicidal thoughts or attempted suicide. We have to see then if we regulate it. There are also long-term studies with more than 0% dependency. And to conclude, because I know that my intervention has to be short, I want to talk to you about the importance of regulating the product, because as you very well know, these plants could also have an artisan use, and it happens in many countries. I was in Mexico recently giving some conferences, and we see this in throughout Latin America. You see that they sell it at bus stops. There's people that's preparing cannabis as a handcraft. But there's going to be pollution with fungi, bacteria, heavy metals, and especially the cannabinoid concentration won't be described, which is what I see the most. You don't know how many milligrams per milliliter it has of CBD or THC. This is why it is very important to have a concept, which is the best production or manufacturing practices. In Colombia, this is set by the regulatory entity, the counterpart of the FDA in the US, for example, where you see traceability from the product, from the growth, from the seed. There is a traceability towards the lab, which is an extraction lab with the right technology. And the product needs to have an expiration date, the amount of cannabinoid that we are describing, having the milligrams per milliliter, and also having an administration route. It could be a drop or a syringe, and people just take what they are being given by the neighbor on Instagram, and they also have to be given by the doctors. As you know, in the Journal of Cannabis Research, physicians and psychiatrists don't even know very well the use of cannabis for some mental health situations. So how can we use or find help from a patient if they ask if they could be candidates or not, if the physician never received a class of the endocannabinoid system or not? They are not interested, or they just don't care. That's why in some countries they are clinics. For example, Canada, they are cannabis clinics. These are reference centers, and patients are referred to these physicians that are specialized. And last but not least, and with this I say goodbye, the use of cannabis is not a first-line treatment, nor to treat epilepsy or mental health. It is always a second or almost always a third line of treatment, and it is always a coadjuvant. We don't want to have alternative medicine. We want to do comprehensive medicine for those patients that are candidates. So thank you so much for your attention. These are my contact info and social media, and you can write me or go to my webpage. Thank you, Gabby. Thank you, my dear colleague. Dr. Manuel Orihuela just gave us a summary, a very significant summary on current status, persistent current status. And Dr. Juan Manuel, I also remember what you just said at the end. For 25 years, I've been working on cannabinoid medicine, and I've seen the metamorphosis of people's thinking and mindset. And something quite significant today is that we have more and more people asking for treatment with cannabis, not as a complementary treatment, but as the basis of the treatment. And this has to do with the fact that new generations around the world have this notion of going back to natural, to unprocessed products, and cannabis offers a lot to this type of people. So I always do this recommendation too. For patients having problems and being managed by a specialist, We need to continue with the management by the specialist, and we will integrate the treatment with cannabinoid. And there are no few patients that after a while turn to an exclusive cannabinoid management. So as you said, it is very important to take this into account, to keep it in mind, and to be attentive to changes, because I think there's going to be more and more people choosing this type of non-conventional treatments, if you want to look like that, if you will. Please stay, Dr. Juan Manuel, just in case there's a question by the thousands of listeners. And before that, I would like to introduce our second speaker. He's a chemist and pharmaceutical, Jose Lacaba Fernandez. His academic education is a PhD in Control and Regulation of Drugs by Uruguay's Republic University. Has postgraduate degrees in theoretical and practical consumption to understand intervening the use of drugs by Flaxo, Uruguay. He's also chemical, pharmaceutical, and biologist by the University of Uruguay. He has participated in national and international training courses and conferences. He's the technical director of Bricola Pharmacy, a community pharmacy. He's technical director of the clinical laboratory analysis, Lacaba Bustic, and he's also a chemist of the laboratory of the Intendency of San Jose Department. He's currently the coordinator of a national program on medicinal cannabis access from the Ministry of Public Health in the administration of Uruguay. In Mexico, we always look very closely at our brothers and sisters in Uruguay, because in an act of sovereignty and bravery and putting the interest of people above even international treaties, they had the vision to give one step towards regulation. They turned into a petri dish so that we could see in the world what happens with a Latin American country that goes for regulation. And we are very thankful for everything that you showed us and taught us. Jose, the floor is all yours. And if there's any opportunities, we will continue with some questions. So please, Mr. Lacaba, the floor is all yours. Good afternoon. Can you hear me well? Good afternoon, everyone. It is a pleasure to participate in this event and to be able to share from Uruguay our experience in cannabis regulation, which next year I will have 10 years of experience in it. I'm going to talk about the cannabis regulatory system in Uruguay. This presentation is about the legislation that Uruguay has followed for the cannabis, unlike what my colleague from Colombia showed. Until 2013, which is when the law regulating cannabis was enacted, cannabis used to be regulated as the rest of the controlled substances by the law of drugs and the conventions by the UN. In this sense, cannabis could only be used for medical purposes or scientific purposes. The Uruguayan law on drugs has a characteristic. Substance consumption is allowed for adults. Cannabis consumption is allowed by adults, but its trade is not allowed, which creates a problem for people then how to buy it if it's illegal. And in the law on drugs, there have been several modifications, but it hasn't clearly defined what's allowed as a personal use and how much is considered to be illegal. Drug dealing. In December 2013, there was a change in cannabis regulation through Law 14.294, where an exception to the law on drugs, specifically for cannabis, was stated. This law 19,000 or 19.172 allows the use of cannabis in three fields: medical fields, research, industrial, when it is not a psychoactive with less than 1% THC in its flower, and the non-medical use, I mean the adult use. The same law was created by the Institute of Cannabis Control and Regulation, and its mission is regulating the application of the law. Now, on the non-medical use, it is regulated by Decree 120/014, and it accepts three modes of access to marijuana or cannabis in a non-medical use, which is the auto-grow or self-grow, belonging to a membership club, or the acquisition of marijuana produced by companies with an IRCCA license for said purpose. Each of these three acquisition modes is regulated by the IRCCA. It has a previous registration to belong and to be able to consume it under these categories. And another characteristic is that the person that registered for self-cultivation cannot belong to a membership club or cannot buy it at this pharmacy, at the drugstore. Only one acquisition mode is accepted. We're always saying that consumption is approved for adults older than 18 years of age, and the maximum amount that's allowed for the consumption, the monthly consumption, is 40 grams, which gives a total of 480 grams a year. Evidently, it is not the same thing to have 440 grams of low THC quality cannabis. Now, for legal purposes, there is no difference. There is no specific difference. We always talk about cannabis with more than 1% of THC. And we can revisit this later on. Now we are going to go over the next aspects that the law in 2013 includes. Industrial use, which is the one that's inclusively for hemp, cannabis with THC content for industrial use, and is covered by the Fishery, Agriculture, and Cattling Ministry, and it covers the industrial use of cannabis. And the third use that's allowed is the medical use and for scientific research, which is regulated by 246 Decree 2021, which is the current decree, which is the original for 246 2015, and it regulates everything related to the medical use at a scientific level of cannabis. It's important to add that this decree respects those established by the law on drug use, and the medicinal use of cannabis in Uruguay is led by the same laws and the same characteristics of controlled drugs and substances, and in general of any drug and medication. So as Dr. Orjuela Rojas was saying, we are still having the theory. What's being sought after is the quality of the cannabis-based drug and medication and its effectiveness. Now, in Uruguay, we have several products. We have exactly 3 pharmaceutical ones. 2 of them are isotopic and dermic, while 11 are of oral use. And all of them are mainly with a CBT component. Since 2019, there is a new law, which is a 19.847 law, which is access to therapeutic and medicinal cannabis. And what it aims is to regulate and promote and allow the access to medicinal cannabis and to allow access to to remove them from the list of unregistered drugs, unknown drugs that circulate in a market that could be called irregular.
This new law for medicinal cannabis monitors a national program created in 2021, which I am the coordinator. It promotes a pharmacosurveillance program and tries to implement the access of medicinal cannabis through the national health system. This is so that it could be incorporated in the benefits of these first level care centers. This is basically a very general perspective of the regularization we have for the access of the different types of cannabis. I guess this is just an introduction to the subject, and I'm open to any questions. Thank you very much. Dr. Lacava Fernandez, this has been a very interesting review about the legal pathways for this legalization, how the people can access this type of medicine, and probably with our own peculiarities. But here in Mexico, we have a system that is quite similar in many ways. Is there opportunity for some questions? Okay, great. We have some of them. So a question for Dr. Juan Manuel. What happens when patients with issues and treatments for cannabis for anxiety use cannabis? I don't know if you get the question. And one more question for Dr. Orjuela. Where can we get cannabidiol with well-established presentations? As far as I'm concerned, here in Mexico, the presentation we have on sale is still not regulated by COFEPRIS. Maybe they cannot answer in Colombia. I don't know if we can answer the first one for Dr. Juan Manuel. What happens with patients with problems and treated for anxiety combined with cannabis? If I guess the question if this secondary pharmacological treatment can be combined with cannabis. Okay, thank you. Well, it's important to have into account that anxiety has a lot of phases. Psychiatry says anxiety is a phobia, anxiety is a general disorder, it is important to have evidence for social anxiety. That's what I mentioned with cannabis. Someone with a social anxiety disorder has its own treatment, exercise, psychotherapy, meditation, medication, but 30% of them are going to be refracted. They still have crisis, they still have anxiety, so they continue with the symptoms. In those patients who still have these refractory components, we can include cannabinoid. And this is interesting. The next questions about the products that are still not authorized by COFEPRIS, but when there's a spectrum of cannabinoid products, the purified cannabinoid is when 99% is CBD. When we decide to remove the THC and the other more than 100 cannabinoids, and it is processed through a laboratory regulated by the government. In those patients, we can mix it with their own medication, and the adverse effects are minimum. One of them may feel fatigue or tiredness, diarrhea because it's an oral oil, but we need intervention to combine with the medication, and there has to be included a person that can subscribe cannabinoid and know about the use. So it cannot be a social network or your neighbor, someone who is really experienced about it. Thank you, doctor. I would like to comment for that question asking about Mexico. Today, we are having a very weird situation in Mexico regarding medicinal cannabis because it is not penalized anymore. We published already some regulations for the research and the clinical use of cannabis. However, there's still a part missing, so this can be done throughout the whole society. So today, people who are bringing cannabis to our country through amparos. This is not the most adequate thing because at a certain point, the strategic legal strategy was very important for their cause. But today we have now rules where every person have to know the rules to be able to be in the production and sale and cultivating of these products. I also wanted to mention something about, and sorry, I forgot, but let's continue to the next question. For chemistry, Carlos, it has to do about the regulation in Uruguay. Good day. My question is about the regulation in Uruguay regarding the medical sector. Which are the patients who get more benefit about the cannabis, and if it's recommended for oncological patients? So chemistry, Carlos Jose. Well, basically, the drugs that are registered are for epilepsy. However, many professional physicians use it for treatment of pain, for relief of pain, especially with chronic pain, and in some cases with oncological patients. Is there a use or recommendation of THC, of CBD in bipolar disorder, especially in maniac episodes? That's a good question. Well, if someone has a background of psychosis, bipolar disorder, the THC is counterindicated. So it is very important when prescribing cannabis, in this case through a psychiatrist, because we've seen that there are very holistic aspects of the cannabis. And if you don't know the specifics, there can be mistakes. So you cannot give THC for psychosis. And with cannabinoid, there has been many studies in bipolar disorder, but it has no anti-maniac effect that is very convincing. So personally, I wouldn't use it for bipolar disorder. Okay, completely agree. THC has a psychotomimetic effects, so we have to be very careful with this type of medicine. CBD tends to be more innocuous, but I would ask our academics that are listening to this to be very careful with the pharmacological interactions, because if CBD as such, as most things and most things, it doesn't represent any type of risk, but the THC can. It can be the other way, as I mentioned. Also, it is very dangerous that there are many coaches and new age psychotherapies trained on the internet, and that they can use cannabis. They want to use cannabis as a treatment, because we have to be very careful. So that's why we need to have very clear regulations. We've investigated cannabidiol sometimes with THC, because sometimes we see only CBN, CBG, that we still have not enough research to be used in humans. So all of these issues about terpenophenols, limonellos, because all of these components are still present in other elements of the nature, in other trees, plants, and they do not have a healthy effect. So the cannabinoid is the one that can work with the CB1 and CB2 receptors and can have a pharmacological effect. So we need to consider, and as I experienced, I say it, when we started talking here in Mexico in 2007, the first time we went to the Senate to talk about these matters, physicians that were very conservative and they were very scared, they were saying that we had to do medicine based in evidence, and we couldn't do medicine based on ideas. Fortunately, today we have more and more evidence accumulating to prove these treatments. And what is going to happen, that physicians that are based on incentives are going to have more of a hard time to adapt, because they're not going to see the economic gain that they used to see in other products. So thank you very much to everyone in Colombia, in Uruguay, for your presentation. Let's hope we can see each other soon. Our speakers have been very interesting. And in name of everyone here in Mexico, from Secretaría de Salud, the Secretary of Health, and the federal government, thank you for your participation. And then I give the floor to the moderator. Thank you very much, Dr. Gadi, for your great work as a moderator in this table. We learned and we got new information, and hopefully our audience also enjoyed this analysis of this interesting subject. This is how we will close the regulation of the regularization of the cannabis use. And I'll ask you to stay for a few more minutes, because now we're going to continue with the next presentation, which is the developments and challenges for the regularization of tobacco control and other nicotine products.
¿Qué tal? Muy buenas tardes. Bienvenidos y bienvenidas a esta mesa de debate con el tema Avances y desafíos en la regulación para el control del tabaco y otros productos de nicotina. Mi nombre es Ricardo Ranz Forcada, estoy a nombre de la Conferencia Interamericana de Seguridad Social para presentar a la moderadora de nuestra mesa. El gusto para mí es presentar a la doctora Luz Miriam Reinales Shigematsu, quien es médica cirujana egresada del Colegio Mayor de Nuestra Señora del Rosario en Bogotá, Colombia, especialista en medicina del trabajo de la Escuela Colombiana de Medicina.
Specialist of with a PhD with epidemiology in the Public Health School of Mexico. She has a wide experience on TV, and she's a researcher and member of the National Research System with level 3. She's chief of the medical area of prevention and control of tabacism in the National Institute of Public Health. Welcome. Welcome and good afternoon, everyone. Thank you for the invitation. Thank you for the invitation today. And it is very important for us from our Inter-American Conference of Social Security, from the point of view of organizer, PAHO, and different institutions at government level, particularly in Mexico, committed in the control of tabacism, CONAVIT, CONASAM, CONSAMI, to put this matter in the center of the second Congress of Mental Health Congress. It's a very relevant matter regarding public policies. And in this table, we're going to have two emblematic cases, the case of Uruguay and the case of Mexico. We're going to listen. In first place, we have Dr. Laura Jambi from Uruguay, who cannot be here right now for her presentation, but she left a recording that will allow us to listen the case of Uruguay. And then we're going to give the floor to Dr. Carlos Gámez from the National Office of Tobacco Control, presenting the case of Mexico with its own particularities. And then we will open a set of questions to answer what's going on regarding preventing and control of tabacism and the new challenges. So if you can help me with the presentation of Dr. Laura Jambi, and we will start with her. Thank you. Good afternoon, everyone. I want to send my greetings from Uruguay. I'm Maria Laura Jambi from the University of República of Montevideo, Uruguay. First of all, I would like to thank the authorities for the Second Congress for National Health, the possibility to be here with you today, participating. I'm going to share my presentation.
Bien, espero que ustedes la estén
I
pudiendo.
hope you can see it. We're going to talk about some of the experience in Uruguay, about the challenges and regulation for control of tobacco and other nicotine products. As I was saying, I represent the School of Medicine of University of República in Norway. I'm a physician specialized in tobacco control from the University of Johns Hopkins. I have a PhD in medical sciences, and I also do clinical practice and research. I am the representative of the medicine school in the interinstitutional consultancy for the Ministry of Health in Uruguay, but here I represent the academic sector, which give counsels the public policies for tobacco control in the Ministry of Health. I have no conflict of interest to declare before this speech. I would like to talk about the epidemiological control of Uruguay and focus in three main challenges: the electronic products of heated tobacco, some challenges of the neutral packaging, and also the treatment of the dependency of use of tobacco. Also, as a final message, we will do an analysis regarding weakness and threats perceived. Our epidemiological control is this: if we observe the prevalence of use of tobacco in Uruguay is from the end of 90s or before, we've had a decrease that started at 30% and currently is in 22.3 of grown-ups. This was greater in males, and also in males we've seen the biggest decrease. We see here that in 2018, the use of electronic cigars was checked. At the moment was a marginal number. But what happened with youngs or teenagers from 13, 15 years in Uruguay with education, we started with similar numbers, and it was a bigger decrease, currently being at 11.5. And at certain points, we even had a prevalence of 1 digit in this population. However, the use of electronic cigar, even occasionally, has reached even 10%. So it's very similar to the combustion cigarette, which is an important threat, we believe. If we see a timeline on how the policies for tobacco control have been in Uruguay, we've seen that it started in 2004 with who agreed the first international agreement of public health, and with the creation in our country of this interinstitutional group that integrated and represented the academy sector and has as an objective to integrate technical from different disciplines to consult the public policies of tobacco control. In 2006, Uruguay was the first country free of smoke in the Americas, and 2 years later, that measure was integrated in a law where also some measures were took about the sanitary, the devices, education, training, commercialization, through a strict promotion of ads and sponsorship, and also sanitary pictograms that are 80% of the faces of the box, the brand. In 28, it brought us with to court with Philip Morris, in which it was ruled in favor to Uruguay. In 2009, it was prohibited the import and sale of electronic devices, not the use. If the person had it from the exterior or illegal selling, it wasn't penalized, but it was prohibited to sell it legally in Uruguay. In 2017, as the evidence moved on regarding that second-hand vapor, its use was forbidden. In 2020, the neutral packaging was implemented, which is part of the challenges. The two most concrete challenges was by decree, the register and sale of some electronic devices using heated tobacco, and also an attempt to weaken the packaging.
Estos dispositivos
These devices, called in literature in English heated tobacco products or heat not burn tobacco products, refer to products that are heated but not burned. Difference to the vapes or electronic cigarettes, these do not use a liquid, but they use tobacco, pressed tobacco in a cylinder called stick, or also insert, and it's very similar to a cigarette, and it is heated close to 600 centigrade, producing pyrolysis and a minimum combustions, and it creates some aerosol different to the smoke of tobacco. So to avoid the register and the commercialization of these devices, the rest of vapes are still forbidden since March last year. This was a decree that didn't count with the support of this technical group. We actually do not are part of this text. Well, we were aware as soon as it was approved and published, so no brand has registered. So it's more a sign of just weakening, making it weak, the regulation, more than a genuine interest of health.
recientemente. La evidencia es
These
bastante
products
reciente.
have been recently studied, and the evidence is also recent because they are after electronic cigarettes. And with the support of PAHO, we did an update and a review of the evidence until 2021 called Evidence Collection, and it is available in the web, and you can refer to it in order to see what is the result of the analysis of this type of studies, of this type of products, emissions, biological parameters in animal models, some on human health and others on how its use is in real life. Briefly, the important aspect that we always hear about, if they damage more or less our body, or if they could be used under a risk focus. Well, it is important to know that the study of emissions that were done of these products are done in laboratories with the smoking machines that are standardized and properly calibrated for cigarettes, for these new sticks, and especially when the machine asks for aerosols and components, then it asks for an exclusive use of this product. If the user in real life, besides this product, smokes or vapes, then it increases the amount of substances that they are exposed to. And almost all of the compounds that were found in aerosols of the heated cigarette is a series of toxic and carcinogen compounds. Some of them are in minor levels, others are in major levels. So there is no confirmation saying that those exposed to these products are exposed to less concentrations of all of these compounds. Yes, they are exposed to less small concentrations, but more concentration of other things. Now, this is not meaning that it is a less harmful product. It increases the tobacco intake, which is related to coronary disease, CPOT, lung cancer. And it wouldn't be methodologically correct, confirm that it is less harmful for health. There are some independent studies of the smoking industry in animal models that have shown the same pathogenic paths that the smoke flows is produced with the aerosols of these products, and the respiratory cells, metaplasm, as well as the pro-inflammatory mediator cells and markers present in the bronchoalveolar area. And when the industry attempted to measure some intermediate parameters, not of health situations, for example, smoke-dependent diseases or mortality, but for example, the spirometric index, for example, the first, second, first ejection fraction, or the C-reactive protein, when comparing the values to smokers with those consuming IQOS, which is the Philip Morris one, we don't find significant measures. So it is incorrect to affirm that there is a proof study saying that the use of these devices are less harmful. In real life, these are not promoted as a treatment instrument or to leave consumption, but they are broadly traded to bring new consumers that could be not initially appealed by these, and their nicotine addiction will start with this sort of elegant devices. And in countries that have had huge penetration, it has been proven that young people use it in dual type of consumption. They still smoke and they still use these products. Now, discussing our challenge with the neutral packaging. As you know, neutral packaging is a way to package tobacco products that use a uniform color in the entire box, which is this greenish brownish color, which is Pantone 446C. It has the brand, but without brand logos, with a standardized type and font and size. It doesn't allow any promotional images.
Mostrado a través de
And it
diferentes
is proven via different qualitative and quantitative studies that this type of packaging reduces the package appeal, eliminates advertising, limits false perception that there's a product that's least harmful than others, and increases the effectiveness of warnings. As prohibitions in promotion, sponsorship, and advertising of tobacco, a cigarette pack was considered the last promotion marketing vehicle in the consumer industry. So standardizing this last fidelizing flagship for consumption is an interesting strategy, and that's proved to be useful for these goals. What happened in countries that implemented the neutral packaging before Uruguay, for example, United Kingdom, Australia? Well, agreeing with neutral packaging, the industry customized and personalized the interior of packs. So we started seeing colors, logos, flavor inside the cigarettes themselves, more cigarettes, thinner cigarettes. When the exterior is already standardized, the interior started having certain characteristics, design characteristics and attributes that made it more appealing for young people. Taking these lessons learned, Uruguay standardized the exterior and interior as a neutral packaging. So cigarettes is forbidden to use inside each cigarette or each cigarette pack the colors, designs, and other characteristics that are against the standardizing the way it's argued in the previous slide. What happened this year? Before the implementation of the neutral event that was in 2020, we started this phenomenon and we did an information collection, and since there was these neutral packs, then there were packs with new design characteristics, more flavor compared to the previous ones, colors and other characteristics. Recently, in February, due to a decree, we attempted to modify this regulation, allowing to incorporate logos, designs, colors, and other materials that would allow to happen what did happen in the US and Australia. And after the neutral package neutralizes the exterior of the packaging, and we had progress in terms of the interior, this new decree in September brought back eliminated the progress that had happened with a neutral package. Several organizations and scientific societies, as well as civil society and the academia, and the Faculty of Medicine asked the president via an open letter that was done with the team, along with the Tabacology Institute of Uruguay, had a legal writ of amparo issued, and this decree was suspended to be defined in a judicial institution. So we are still with the previous decree, the one that's more comprehensive. Also, the authorities admitted that this change was by the request of the tobacco industry, which shows a huge interference in the commercial interests above health interests. Last but not least, I will discuss some challenges on treating dependency. We have had some progress in being a mandatory service provided. There has been a team, there has to be a team covering smoking. It has been covered mostly with some access difficulties and waiting times, but there have been training campaigns on behalf of training teams, a clinical practice guideline, a manual, a user-friendly manual, and a centralized financing of at least 2 of the pharmacotherapy, bupropion and nicotine gum, for the nicotine replacement therapy, which is funded by the state, whether it's the use of a public institution or a private institution. There are agreements. So at the National Fund of Resources, which is an institute that funds highly specialized procedures, also funds smoking treatment. What are the challenges that we have left in terms of treating dependency? Many of them. Beyond this agreement with financed medication, beyond them working, we need to have a systematic story. We need to have patients contacting the different health systems via the nursery department. We need to have more contact with pregnant women with mental health, with people with mental health, and with in vulnerable communities, because we haven't had access to all of them. We also need to have the intra-hospital problem. It is still showing problems and not systematized. We want to share this SWOT analysis where we recognize as strong points and weaknesses, the internal and external ones. For example, a strong point would be a broad administration of the framework via this series of measures that I shown during the initial timeline. There is a technical advice. Yes, the last measures were not taken into account, but we have organically a commission that meets every 2 weeks at the ministry to continue advising based on evidence, with studies, literature, with new local researches, the design of policies and decision-making. The civil society is strongly organized, and in general, there is an acceptance, broad acceptance. The internal weakness is that there is a scarce budget for campaigns and for new programs. Right now, we have political support that varies, that fluctuates, and as I said, there have been 2 attempts of standards contrary to what we would like to see. And there is a network to other public agendas, gender, people deprived of their freedom. Many of it cross the path of the tobacco agenda, and we feel that we should also be crossing other stakeholders in order to start synergies in other programs that are also being developed in our countries. As external opportunities, we see these institutions, regional cooperation, exchange with regions' colleagues, generating local and regional evidence that can be used to keep the design of new policies. And clearly, the threat here is the tobacco industry and its new emerging products that tend to bring new consumers, particularly our young citizens. I would like to share this quote by Maria Benedetti. When we believe that we have all of the answers, then suddenly all of the questions changed. In Uruguay, we trusted the path that we had taken in terms of tobacco control and the impact on our health, favorable indicators. However, we see new problems to face every day, new challenges, new barriers that we have to address
y por lo tanto debemos
with new
seguir
strategies. Hence, we have to be vigilant to move forward in a policy that clearly favors people's health. Thank you very much. This was a very clear presentation by Dr. Laura Yambi that historically shows a decade and a half of tobacco control in Uruguay. Now I would like to pass the floor to Mr. Gámez, Carlos de Sus Gámez. He is the chief of the National Office for Tobacco and Alcohol Control, CONADIC, so that he can share Mexico's information and how this contrast at a region level has been, and how the epidemiology has been happening, as well as control policies. Welcome, Carlos. Thank you very much, Dr. Reinales. First of all, could you please confirm that you can hear me? Yes, we can hear you very well, and we can see you very well. Well, thank you very much for the invitation to participate in the second International Mental Health Congress. To me, it is a privilege to participate with so important persons. Dr. Miriam Reinales, for example, she's our moderator, our distinguished moderator and a reference in tobacco control policies. And also Dr. Laura Yambi from Uruguay. She is joining us online, and it is important to mention that we have followed closely the tobacco policy control from Dr. Tabaré Vázquez times, the former president, that just as in Mexico, he was awarded a recognition by the WHO due to his exceptional contributions to tobacco control. And in this sense, besides appreciating the opportunity to share the work of the Ministry of Health, CONADIC in general, and the tobacco control industry in Mexico, I would like to share that this presentation, we would like to focus it on public policy from the perspective of international governance of tobacco control measures represented by our charter, which is the Tobacco Control Foundation. So without any further ado, I would like to start, but for some reason I cannot share my screen. I think I'm not being able to continue with my presentation. I think you can see my slides now, right? Well, I don't really intend to elaborate on the important health problem that smoking represents to Mexico. I think that today, the world is still flabbergasted by the lethal virus, COVID-19, that has killed 1 million people globally from the beginning of the pandemic. However, I think we are forgetting other pandemics. And we have the non-transmissible or communicable diseases, where smoking plays a very important role as a main risk factor. And in this sense, According to the WHO, smoking is responsible of more than 8 million deaths at a global level. And in a country such as Mexico, close to 120 million people, smoking is related to preventable death in more than 63,000 people a year in this sense. So the size of smoking epidemic, it's kind of hard for me because I think there is a delay when I switch slides, but well. And in this sense, I think it is important to highlight in governance and tobacco control measures setting, just as the pandemic of COVID-19, we also have a proven effectiveness vaccine. We have a vaccine supported by the WHO, a cost-effective vaccine available for everyone. And in this sense, it is represented by the agreement for tobacco control from the WHO, which is the first treaty negotiated under the WHO that's based on mandatory measures. They are mandatory for state members, part of this agreement, and its a goal is to protect present and future generations of the devastating consequences of smoking. And in this sense, also as of 2003, that the Marcon Agreement was adopted and enforced in 2005. In 2008, the WHO also launched these Empower measures in order to bring back to reduce smoking. This is a roadmap to effectively implement the agreement. And in this sense, this program, this Empower plan, with 6 measures, basically proposes the most cost-effective propositions, and at the same time, each of the measures turns into indicators to be able to measure the effectiveness and the progress in this sense. Mexico was pioneer in tobacco control measures, and Mexico was the first country of the Americas in signing and ratifying the WHO framework for tobacco control. In 2004, it was ratified by the Senate according to our charter, Human Rights Charter, and to our Constitution. And when the agreement was enforced in 2005, it was already part of it. However, it was a relatively long road to go in order to have international governance of tobacco control measures. And from that point of view, to be able to take from international recommendations and turn them into a domestic policy. And this internal or domestic policy is reflected as of 2008, virtually 3 years after the agreement was enforced with our national law, which is the general law for tobacco control, and next year with the regulation that establishes the specificity in terms of law application. In 2008 and during previous years, we reached a crossroads because there have been several attempts from 2005 in order to have a national law. However, in 2008, there had to be a decision made between moving forward with some deficient laws or to restart from scratch. And the decision that was taken was moving forward with the deficient law in places free from smoke and the sponsorship and labeling laws, with the idea to amend it next year. Unfortunately, 13 years went by since 2008 until we were able to amend and to meet that goal of truly comprehensively complying with the framework mandate. So as we see, there is an impressive impasse of almost 13 years where we were able to amend the law, which happened until 2021, and it was enacted in 2022. And in this sense, as of this administration, specifically as of 2018, 2019, we readdressed once again leadership by Mexico in tobacco control. What how's Mexico doing in terms of these indicators, in terms of this Empower plan package that we were just talking about? These indicators were out of these 6 measures. we can say that between 2020 and 2021 until today, Mexico reached a significant progress, mainly based in this amendment to our domestic law. And virtually, we were able to reach the maximum level of implementation in two of the measures that we had pending from the gaps that our law had. And these were smoke-free spaces. And in terms of advertising, and after 13 years of fight and struggle, we were able to modify the general law for tobacco control of 2021, where virtually their main characteristics were fully complying to 100% smoke-free areas, where these areas were increased, and also the protection with emissions was also implemented by the new and emerging tobacco products. And in the same way, we moved forward to the promotion and sponsorship amendment. And also, as of the law's regulation, we are promoting the prohibition of tobacco products exhibition as an indirect measure. So out of the 6 indicators that we have today, it is complying with 4 out of the 6 levels in a maximum level of implementation. And at the end of this administration, hopefully we would have 5 out of 6 having pricing pending for next administration. And in this sense, it also caught our attention what Dr. Jambi was saying with the challenges that Uruguay has been facing in terms of new and emerging tobacco products. And in this sense, Mexico has also had a significant progress. And it is important to highlight that in 2022, in the framework of the Day Without Tobacco, the WHO granted Mexico an award to the president by the WHO director due to the political commitment in this sense. And also with the same idea in mind about these new and emerging nicotine and tobacco products, because as Dr. Jambi was saying, this is the way in which we have to call them due to its concept. And normally people say traditional products or conventional products. Well, actually, these are field products and new and emerging products. And I'm talking about this poor perception of conventional products, because actually there cannot be conventionality in a harmful product as this is, in a negative, in a product with such negative characteristics as this. And Mexico has had some progress also in regulating new and emerging nicotine and tobacco-based products, in the sense that the main detractors of tobacco control, mainly led by the industry of tobacco and its associates, they have held that Mexico should move forward towards the regulation of this type of product, when actually Mexico has already regulated this type of products through the maximum regulatory level, which is absolute prohibition. And as of many of regulatory options that the WHO has shared, so that countries can apply it. And in this sense, the maximum level lies in absolute prohibition, which is from its origin lying in the general law for tobacco control. And in this sense, considering the proliferation of this product in the most vulnerable age groups, fortunately, we have had the accompanying and support of one of our main new champions in the fight against tobacco, which is the president of our country. And in this sense, I wanted to share an analogy, being, of course, respectful, with the former president, Tabaré Vázquez of Uruguay, that truly committed and added a fundamental ingredient in the development of public policies and its strengthening, which is political will. And in this sense, the president of Mexico has accompanied us in this sense And even from the point of view of recognizing that this is an industry that bases its profitability on youth health, particularly. So we have had important support that has been seen in different decrees at a presidential level. One of the challenges that we face in Mexico, and that is actually a common challenge in the world on this type of devices, is the strategy, not only of the sophistication of these products, but also the constant transformation strategy of these devices.
Uno de los aspectos que hemos visto
Some
desde
of the aspects we've seen from the first generation, since the first generations, is that the industry tries to make a difference to say, this is not a cigarette, well, this is not a nicotine product. So there are different categories that sometimes may seem actually with the attempt of going over regulations. Fortunately, WHO has clearly categorized this type of products as these three main categories. This is electronical systems with nicotine, without nicotine, and the alternative products for nicotine consumption. So what we're seeing today, not only in Mexico, but in the world, we are witness of the new lie of the tobacco industry. It is important to recognize that the tobacco industry more frequently each time is those who develop and commercialize this type of products is the same industry. Like, for example, IQOS, commercialized by Philip Morris International, another product that I don't want to mention its name, but also by one of the competitors. So what we're looking is the same lies that we've seen for decades, when it seemed that tobacco industry, that one lie that told 1,000 times turns into truth. So this type of products are 95% more safe, but it's actually no evidence about that. On the contrary, we have found that these affirmations lack actually of a scientific evidence. Another aspect, they say that they are less harmful, and we have to recognize, even when scientific evidence says this type of devices in any of their categories have negativity because they are out of their consumers and exposed to their.
creo que ha encabezado la narrativa del gobierno de
Something
México.
that has also used the government of Mexico is that these products are harmful and cannot be considered ordinary consumption products. On the contrary, because of the negative externalities, it has to be strict and different from the products of ordinary consumption. Another myth is that it's an alternative to stop smoking, which actually is not. The scientific evidence, and Dr. Jambi was mentioning, actually people who start to experiment with this type of products actually have a dual consumption where they hook with this addiction to nicotine, and then they keep on using these type of products. So what scientific evidence has concluded is that there are different negative externalities, that the aerosol, which is actually not a vapor, it's a smoke that has been considered by the WHO, and it represents a new source of contamination of air. And all of this exposition to these heavy metals represent a very high risk to the population that cannot be denied. So what we've seen regarding this type of products, we see the same concerns that we have with regular combustion cigarettes, but I think I would think even worse. Also, liver failure that we've actually seen in some of these products. So to have more scientific evidence, the Mexican government with the COFEPRIS, kind of the FDA, Mexican FDA, they had a chromatographic analysis of vapes, and they found many toxic substances that are not reported in this type of products, and that the vaping industry just reports some of them. So in this sense, even though this is a methodology in construction, then we need to have more evidence to have these, to know the risk associated to these products. Regarding the challenges from the Mexican government is to keep these type of products basically from what it is recognized as the precautionary principle of health. Almost all constitutions in the world establish the right to health, and the fact that Mexican state, as any other country, opens to allow the regularization and commercialization of these products can put into risk this right to protect health, because there's no conclusive evidence of the consequences of these type of devices. The tobacco industry plays an important role to mine these policies and see the decrees that have been promoted in Mexico to promote the export and import of these products, especially in one same category, in a same commercialization product, as it can be the heated tobacco products, which are not only in Uruguay, as Dr. Jambi said, that have tried to turn around. In Mexico, we've seen that too, but there's been a margin to regulate and modify. So which are the challenges for the Mexican state? The main challenge is the use of our reglementation. The law was changed last year after 13 years of standby. And now we have the challenge that we've managed through different actors within the Secretary of Health and outside, where many organizations at the international level have played an important role. We have a regulation that could be published hopefully before the year ends, which closes some of the gaps regarding free smoke areas. And in this sense, the law needs to prohibit all type of ads, directly and indirectly. So the exhibition at a point of sale is prohibited, and the diffusion of corporate responsible social responsibility must also take into account. Also about the emissions of this type of products that added to the different decrees of import and export, commercialization, transit, and distribution of these products. They contribute to lower, from this perspective of international governance, in a domestic way, these type of public policies. Another challenge is to follow the path of Uruguay, of Canada, Panama, and other countries in the world, And we believe that this may be ready at the end of this administration in maybe 2024 for the illegal commercialization of these products to strengthen the cooperation to ways, because as Dr. Jambi says, those challenges in Norway are the same we have in Mexico and are the same of Panama and the same Canada had any other country of the region, because we are confronting to one of the most globalized industries. Finally, to keep the prohibition of these products, despite the different debates that the vaping and its associates can do, so that through we can avoid the commercialization of these products. So thank you for the opportunity of being part of this panel.
Muchísimas gracias, Carlos, por esta excelente presentación, muy completa.
Thank you for your presentation. It was very complete and showing the reality that we have in Mexico. I would like to now give room to questions, because this information exchange is very important. Here at the chat, it says, good afternoon. Some quick tests that we can use to assess and do a reference. I'm not clear about what they mean, a quick test. But I would like, Carlos, if we could emphasize in this national work in these contact lines that we have from CONADIP to address all patients and all smoker patients that require to stop smoking, to give these, to call this. I don't know if you can help with this information.
Sí, claro que sí. Muchas gracias, doctora.
Yes, thank you very much, doctor. 2 years pandemic to Zoom, and we still make some mistakes. So basically, one of the main strategies within the Secretary of Health in Mexico is to give support to stop smoking, to promote this ceasing of tabacism, and we do it from the giving support strategies and brief counseling to abandon the use of tobacco, psychological support, and eventually to be able to give pharmacological options. This is one of the biggest challenges that we have not only in Mexico, but in all the Americas, because in a country where we are in a transformation process of the national system or the national health system, it has been difficult, at least in Mexico, to achieve a wide coverage to give pharmacological treatment to all those who need it. However, I would like to highlight some of the challenges that Dr. Jambi also mentioned, which is financing and the technical cooperation by many international organisms, but also in a bilateral level. So to be able to take advantage of the best practices and be able to finance to strengthen these systems that may be offered and complement these cessation support from the pharmacological point of view too. Thank you. I would like to make a final comment. Within these policies of control, that do they synergically work individually and for the population? And even though we didn't comment it in the presentation, we need to take into account that there's a package of policies, taxes also, that are not only going to help that the youngs don't start smoking young, others to stop smoking, and also those to stay in abstinence. Also, this package, fiscal package, will help us to have more resources at a certain point can be destined to all of these strategies for prevention at an individual level. All of these strategies are also included in the public agendas, gender agendas, poverty agendas, and the objectives of goal of sustainable development. So as you can see, this is an integrality, a synergy of policies that do work and that we need to have make them sustainable throughout time. I'm not going to use more time because we have other roundtables, but thank you, Dr. Laura Jambi and Professor Carlos Gámez. We will stay in touch to share the information about these matters. Thank you. Thank you for your participation. Particularly, I would like to thank moderator Dr. Luz Miriam in this debate of the advances and challenges for regulating and control of tobacco and other nicotine products. Now we're going to go to the roundtable, the importance of the strengthening of mental health and addictions, adoption and implementation of public policies. I'm going to introduce Dr. Francisco Paredes Cruz, the dictaminator psychiatrist of the Coordination of Assessment of Health in Work in the state of Mexico. I will leave his resume, surgeon by the Faculty School of Medicine of UNAM with a specialty in psychiatry. He's been has been a recognized work of a high specialty of the Pediatric Hospital of Siglo XXI Hospital, coordinator of the academic section of psychiatry in the Mexican Association of Psychiatry. Currently, he's a psychiatry in Estado de México Oriente in IMSS. He's also a member of the same Academy of Psychiatry and Mental Health. Thank you. For me, it's a pleasure and an honor to be in this roundtable about the importance of the strengthening of mental health and addiction. We've tried to have the participation of many experts, especially in the state where I work. So let's start with Dr. Carmen Martinez, who's going to talk about the experience in many countries. I don't know if we have Dr. Carmen there. Good afternoon, yes. I cannot show my video. Okay, we will show the video in a while. In the meantime, I want to do a summary of her CV. She has a Master's of Public Health by the European University, also of Community Network, and a PhD in the University of Catalonia. She's mental health consultant in Physicians Without Frontiers, and currently she is from the regional organization of PAHO. Dr. Carmen, a pleasure. The floor is yours. Thank you very much for the invitation. It's an honor to be part of and contribute a little bit with the organization of the Congress. I hope you see my screen.
Sí, doctora, le estamos viendo.
Perfecto, perfecto. Bueno, realmente es fundamental
It's fundamental to talk about how it should be management regarding mental health and addictions. I'm going to talk about some measurements that I believe it's important to having to take into account. Dr. Renato Oliveira was giving us details about how we are at this moment in the region of the Americas. What's the main picture? I didn't want to skip it because I want everyone to see it, because I believe it's the basis on why we establish the directory where we believe it's most important. According to the indicators, there are different indicators, and among those, we have this AVD, which which is a fifth load. If we use other indicators, we talk about a third of the load. So we need to start with that very clear vision of the real demand that we have currently. At the same time, we start from a series of resources and services that are completely insufficient. 3% of the public expenses regarding health for the Americas, only 3% is destined to mental health. From here, from that 3% to fifth are destined to psychiatric hospitals. So we still are that something that goes against the new model that we are trying to defend. From Mexico, at least, I can see. But in general, internationally, it's the same. Also, mental health workers are still very scarce. There's a lot of different. There are countries that are around 2.1, even 51 in some other countries. Still is not enough, and at the same time, we still have most of the resources focused in that specialized care, specifically in psychiatric hospitals, compared to the community level. So the treatment gap takes us to 71% on average. 71% of these persons are not receiving any type of treatment. So I believe this base of concern is clearly fundamental. And then I go to the big picture where I believe we need to focus, which is the real right to health, the fundamental right for all human beings. And we keep a low access and availability of services, which leave us in a very unjust situation. That was mentioned in the Ottawa letter in '86, but even before, and unfortunately, even though we have some advancements, there's still a very insufficient situation at many levels. I also wanted to remind you the main functions of public health, because I also believe that we need to see how this is in case of mental health. Which are these? The first one is monitoring and assessment of health and the well-being at all levels, like social determinants, structure, etc., And how are they affecting surveillance and control in management, risk management, research, and risk management of knowledge? Even there has been a good change in the last years, there's still a lot of work to do regarding investments. Also, the development of policies, which are policies, legislation, and regulatory frameworks in general, participation and mobilization that is very necessary at all levels in which we're working on. The development of human resources and in specialized attention and in general attention. Drugs and other technologies, financing, as I mentioned, is one of those key needs that justify why we need to move forward so imminently. Access to services and the coordination at all levels in health sector. Also the perspective that we say, not from the promotion of health, mental health specifically, but health in general. And also to address these social determinants. So it's a whole cycle where we will start with the policies, but we need to assign the resources, real access, and always to reassess. Let's forget there are some basic principles that have to do with the ethical values, the social determinants, to guarantee access and to widen the directory by the authorities. Also, policies and laws regarding mental health and substance abuse should be aligned with many aspects. Also, more new aspects, even though they are not really new, like climate change, migration, racism, colonialism and neocolonialism, discrimination based on gender, sexual orientation, age, capabilities, etc., poverty and other inequalities, education, and other areas, fundamental areas that need to be coordinated. Other aspects as violence and crime, and also sanitary emergencies as COVID-19 and other type of emergencies, and also matters related to the health system. I think Mexico is a very clear example of the current transformation and the need to take all of these elements into account. How can we put the rectory on its first phase so that it really works to channel all of this transformation? Well, knowing the problem. From a deep analysis, finding the needs in general of the population and specific groups, the most vulnerable groups, also integrated with a real social participation of the cycle, and not only at particular moments where their participation is clear and obvious, but it's needed in all phases. Also to highlight the experience and the families and the groups and associations that have a fundamental task here. Also, the programming in the health sector and intersectorial. Also, talking about protection, justice, and work environment to achieve a real transformation, to strengthen resources at all levels, truth communication that can really include everyone in the same framework so that it's effective against stigma to move on with a better mental health and also having a continuous monitoring.
Este pequeño gráfico era solamente como
Now,
para
this graph aimed to give you an example of what are the key actors and stakeholders, and I've been mentioning some of them, these commercial sectors, employment, justice, social services, education, etc. The Ministry of Health, the National Ministry of Health, or the National Institute of Health. All of these also interrelates with those stakeholders at a municipal level, at a specific region level, but also there are other fundamental stakeholders at a municipal level, public providers, private providers, and associations such as NGOs and other groups that are fundamental to understand those progress and those needs and to be able to result into that true transformation. Now, public health measures, we have something quite clear, which is that we have public policies that shape the way to follow. And then we have a real availability and access to services. So this hard balance is fundamental so that we should never forget that from the leadership. If we keep ourselves in clear public policies in terms of where we're headed, but we don't take into account, truly take into account, or if they do not fit, if those services or programs do not fit, as well as the challenges, then we are never going to be able to have a public policy that's effective. And to conclude, I would like to add also the policy for mental health improvement by PAHO that the Ministry of Health secretaries have signed very recently because of the importance that they have in governance, leadership, and also in directorates. It has 5 strategic policy lines. I won't elaborate, but the first one talks about promoting leadership, governance, and multi-sectorial collaboration and mental health integration in all of its policies. Hence, it is not only health-wise, and I wanted to stress that the other lines have more to do with service access and quality of those services and prevention and reinforcing integration of mental health in emergency contexts that are so important lately. And last but not least, strengthening data of evidence and research. In this first strategic policy line that I already mentioned, I wanted to highlight some elements. Design and implementation of those policies, plans, and national laws for mental health need to have that very clear path based on the properly analyzed and identified needs in specific groups that have to be targeted to. The right allocation of resources in a timely, efficient, and equitable way for mental health. The importance of inclusion, as I said, throughout public policies and strategies, and that is a focus for the entire government society, not only from one perspective. Hence, it is fundamental not to forget that these policies, these plans, these laws are never enough. They need all of those steps that I already mentioned before. If not, they are going to just be dead letter. They are just going to turn into files that will never see themselves implemented. And we have many challenges ahead. And if we do not take them into account, and in that sense, actually, I would like to stress the role of Mexico. Some time ago, especially for the last year, via that amendment of the Mental Health Act that has a clear direction towards the model to be followed, and also the political commitment and the high-level promotion, which are fundamental. Today, we've seen how in many countries that political commitment has been highlighted. However, we haven't been able yet to have
para esa transformación.
the right necessaries assigned, allocated for that change. And that's what I wanted to share with you. Thank you very much. Thank you very much, Dr. Martinez Viciana. It is very important to know how this experience is in other countries. And now, through Dr. Molina Leza, we'll be talking about the directorate in the health system in Mexico. And very quickly, I am going to read about Dr. Joaquin Molina Leza's professional career. He studied odontology at Havana, Cuba's university. He has a specialty in health services at the University of Havana, Cuba. And he also works at PAHO in Washington, D.C. He's a consultant in health systems in Washington, Nicaragua, and Mexico. He's a temporary representative of PAHO in Mexico, Guatemala, Panama, and Brazil, and professor of the stomatology faculty. And currently, he's a strategic and analysis representative for INSABI in Mexico. Dr. Molina, thank you very much for sharing your experience with us here in Mexico. The floor is all yours. Thank you very much, Dr. Francisco. Good afternoon, everyone. So I assume that you hear me okay, right? Could you please confirm? Yes, we can hear you very well. And can you also see my screen? Very well, thank you. So could you please just go to full screen? You don't know the battle, the struggle. I mean, I'm just trying. Could you please tell me how to do it? Yes, down to your right. I will show you how.
Aquí, ¿verdad? Sí, justamente con el sucursor, si pudiera colocar el puntero más o menos donde está el logo del instituto, del IMSS. Sí. Abajito, justamente, ahí se va a encontrar con el modo para presentación.
No lo sé bien. Pero
oh, I'm so sorry, I cannot find it, but someone's gonna help me. Thank you. Someone's gonna help me.
Casi lo logramos, pero bueno, voy hablando.
So I would like to thank the organizers while I go to full screen for inviting me to this second International Congress on Mental Health. Thank you so much for being so kind and inviting me. And thank you for inviting the Wellbeing Health Institute in INSABI, such a young institution participating in this event. First of all, I would like to make a reference. Sorry, I don't know what's happening, but we cannot go to full screen. Maybe when I shared my screen, I was not able. Yeah, it's okay. We can follow your screen. So it's okay. Yes, I would like to start my presentation talking about some key ideas to understand the Directorate of Public Health in all of the health field. And of course, mental health is part of public health in general. So the first one will be improving the health of population, which is still the main mission of public health. That focus should never be lost because it is the interconnection towards mental health directorate. And Currently, as internationally accepted, we have the recognition of social health determinants that modify public health view addressing collective health problems and needs by populations and its causes. To me, it is very important to stress this second idea. Actually, when we understand the social determinants of health, some things change in the health system. And this is why the traditional concept that we had, that the entrance door to health system was the physician or the health center, the polyclinic in certain countries has changed completely to understand that the health system entrance is where people are born, developed, and grow, where they go for fun, where they grow old also. That's the true door. Hand in hand with health characteristics lies the other important idea, which is that social, economic, and political aspects play an important role. They determine health and equity. And very clearly, I would include mental health here. It demands innovative responses by health systems and also better prepared health systems to understand the proposed challenges. I feel that those living in the field of mental health and promoting the community attention model understand this key factor, the concept that responses in health are within the capacities of the ministries of health and other service provider institutes is an idea that has been left behind. Health is decided in other fora where, as I said, people is born, grown, plays, develops in society organization, and how they disseminate, they divide the fruits of society. And very traditionally, the first concept of health directorate was used for many years. Actually, when I received my education, I'm talking about the 1980s, when I received my education, it said that the directorate was the exercise of responsibilities and substantial competencies of public health in the context of government and society. I didn't write down that definition because I don't want for it to stay in the minds of the people listening to us. But that sort of decision made us think that it was a small taxonomy. Two elements, and that was that. First, issuing standards, regulations, and patterns, and the second was the exercise of supervision, control, and assessment of implementation at a subnational level of those standards norms that were issued. Today, this concept has been left behind, and hand in hand with the key ideas that I mentioned, there is a third one. There is an exercise of a third notion, the exercise to directorate. And this talks about health services and health authorities. They need to have invitation and calling and leadership characteristics and for public health. And once again, the listeners of these events can very well understand most of the responses in the health of community and mental health system that not only lie in health services, but they are in the society and how they support the convention that they have. Doctor, sorry for interrupting you. We don't see your presentation. You can send us your presentation and I can share it. We are in slide number 4.
Muchas gracias.
Muy bien.
Perfecto. Gracias.
Solución efectiva. Un toque, por favor.
Effective solutions. Thank you so much. So I was saying that once again, people working out in the field of mental health and specifically promoting community mental health understand very well the leadership capability. Not all of the answers health-wise, and this is clear and clear, are within the capacities of health institutions and health bodies. Sometimes there are different development bodies and very significantly in the community and in the families of people. Next, please. So in this framework, I would like to define what directorate is. And I like a definition that PAHO did in 2017 as a precursor of the essential functionalities of public health. Before me, the doctor that spoke before me, Dr. Carmen, explained that this is the capability of leadership of the health authorities to form and support a collective action that allows the creation, strengthening, or change of governance structures within health systems. I think that with this notion or with this definition, that is short but concise, by PAHO in 2017, it is clear that this directorate is a health system that is in transformation. We can understand it. It's in permanent transformation in order to provide a better response to people's health. This same definition was incorporated by the government in order to provide a foundation to public health functionalities in an indispensable way. First, that it's a receiver of what people think about health. It is the government institution that should receive all of the health messages, its vision, and the needs that the population issue. And the second one is being able to act as an authority to be able to promote health. 5 elements that can be judged surrounding this concept. I would start by regulation, which is down to the left. So directorate or governance is the exercise of regulation. This means developing intersectorial initiatives, developing and promoting leadership in health that's effective, and last but not least, exercising the essential functionalities of public health also in governance. And directorate. Dr. Carmen Martinez also mentioned that there is a better understanding and a clarification of what governance and directorate could be when PAHO published in 2020 the update of the essential functionalities of public policy that she very well reflected in one of her slides and in her explanations. And when she placed the directorate as one of the pillars of this functioning, well, if at some point, especially at the beginning of the 20th century, it carried over the neoliberal health systems that was quite promoted in the American continent, it was understood that the governance was about financing, service rendering, and modulating the different service providers, institutions. Today, that's not a current concept. The governance or directorate is one pillar of public health, and we are going to see this present throughout its functionalities. Next, please. What you see here is the same slide that Dr. Carmen used in her distribution in level 11 functionalities that PAHO have promoted. They are widely accepted by most of the continent's countries, grouped in 4 specific areas, which are the ones mentioned in this circle. And it has been discussed in detail. Now let's go over the Mexican health system. The concept of change today is quite present in the Mexican health system. Very recently, so 2 months ago, in the official Gazette, as a regulation for all health service providers, because remember that Mexico is a very segmented health sector with around more than 20 service providing institutes, 4 larger ones or 5 larger ones, IMSS, ISSSTE, the Ministry of Health, and Pemex, and the National Guard. But afterwards, we have other social security institutions in 21 states in the country. The Marine also has its own security, but well, they published the model for well-being, Más Bienestar, in the official Gazette, which brings a whole new vision of the health system. Unfortunately, I don't have enough time to address that. This is the image that summarizes that system. And to the right, we see the 6 values that support that attention model: free, accessible, timely, universal coverage, continuity, and quality. These values permeate any typical division that we do of the health sector, and the mental health sector is included. And it has a huge value in the Mexican health system. Each of them meets and provides solutions to old problems of the Mexican health that have become acute for the last years because of the health sector neoliberal ways. Mexico charged for attention, provided a basic service package, and the rest was to the authorities' criteria, if it was to be practiced or not.
Salud mental era una de las áreas afectadas por este tema.
Mental health was one of the areas affected here, where the services were not provided for free in all situations. Also, accessibility, timely, universal coverage, continuity, quality were not always provided. So governance needs to innovate in the health sector. It has to be skillful enough to see all of the opportunity areas beyond the traditional exercise of authority, to start working and moving an entire society towards another development and economic sector, understanding its groups, its preference, so that they can integrate. So they have to move forward a model, a health model, that has excluded mental health for years. In my presentation, I want to share a personal comment, because it is not necessarily something that has already been discussed before, on how to strengthen the governance of health systems in the current national Mexican surrounding. It is a small paragraph that I would like to read. I'm talking about the increase of the capacities of health authorities to promote a health system that's supported by primary attention. What this may mean is that we are talking about a governance which is not doing what was done before. We need to increase capacities. We need to have our health system based on primary attention. And this also has to include mental health in a community manner that needs to have as a goal health protection. This is taken by the Mexican Constitution. The word universal and health protection appears there, and to have health promotion activities for disease prevention and health recovery. And especially, importantly, not to restrict personal services. Personal health, community health, individual health, and public health are not considered personal because they work together and they do not divide people and population. Next, please. To conclude my presentation, I would like to share a couple of key takeaways.
He expresado Una primera relacionada con la rectoría.
The first
Una
is
primera,
related
el
to
enfoque de liderazgo y poder
governance.
convocatoria.
The focus of leadership
Que rebasa con mucho la
needs governance that has to go that has overpassed or surpassed the Ministry of Health. We need other resources, other understandings, and other support so that we can build health as it should be. And the second idea, that's also part of
comprender que
governance, is understanding that we need to commit other stakeholders with health, which won't displace the governance of health authorities in exercising health. We are still responsible because we are the ones that have knowledge and legal mandate to exercise health governance, but we cannot do it ourselves alone. We need many others to be able to do it. That's all I wanted to share with you. Thank you so much for the opportunity. Thank you so much, Dr. Molina. We would like to thank your participation. Could you please stay on the line just in case there are questions?
Y bueno, para mí es un gusto también presentar a la
And to me, it's an honor to introduce now the head of the Technical Secretariat of the National Council of Mental Health, Diana Tejadilla. Diana Tejadilla has a master's in neurobiology, and she has been a director of the Technical Secretariat of the National Council of Mental Health.
Es un gusto que esté aquí con nosotros y pues adelante.
Thank you so much for being with us today. Thank you so much. It is a pleasure to be with you today. So now I will share my presentation with you. Please let me know if you can see my screen. Yes, we can see your screen. Could you please just share it in full mode? Perfect. Okay, so today, there's something very important for me. I want to talk about how federal authorities in charge of governance in mental health and addictions in our country, as a result of Dr. Alcocer's mandate, have been working and exercising, first of all, this governance, but also applying certain strategies and programs. For many years, Mexico hasn't had a true revolution in terms of mental health. First of all, we have three important aspects that, first of all, is the opening of the psychiatric ward La Castañeda. 63 years later, there's the Castañeda operation that meant destructuring this hospital in order to bring people, in order to bring it outside major cities. 47 years later was that after the instruction of Dr. Jorge Alcocer, the transformation of the mental health and addiction system was approved, mainly to put it on the primary attention support. First, I want to declare the MAP, which are the principles of primary attention that include comprehensive attention in 68. And then there was another series of technical inter-American standards that and what they propose and what they invite us to do. So we can modify and trace principles, restructures, in general, how we're going to develop them and how we are going to implement these programs in health and addictions in our country, as of all of these international recommendations of the different standards, or the recommendations by the WHO, and I won't elaborate, but they are closely related to being able to modify this medical model towards an ecological model, a more community-based model having to do with prevention, promotion, more than only attention in mobile units or hospital settings. In this sense, and also considering more recently the SDGs having to do with health and well-being, we created the Mexican legal framework to be able to know all of these standards and regulations and align it to the SDGs and to the goals of this government, and to be able to align actions and concepts, especially in the territory, not for them to only be in a nice document and a proposal, but also to be able to apply them and to implement them. So more territory, less desk.
Momento, el doctor Alcocer instruye al doctor Juan Manuel Quijada, que es el líder del proyecto de reestructuración del sistema de salud mental y adicciones en nuestro país, para que le haga una propuesta.
So he can give a proposal, and since 3 years ago, we've been working in coordination, knowing the federal instances that participate in mental health and addictions. We give a proposal from the attribution, make a fusion, and work in collaboration, psychiatry, technical secretary of Mental Health Council, and the National Commission Against Addictions. So starting from this collaborative work, knowing the international standards, Mexican legal framework is how we understand the situation in our country. This is a proposal of who? For the distribution or optimal combination of services, where in theory, we should be investing more in self-care, and from there up, less budget in informal community care, first level care, then general hospitals, and then psychiatric hospitals. What we found is that this service pyramid is actually upside down. The biggest part of the budget is then destined to the operation of psychiatric hospitals, where people arrive, but in a very deteriorated state and with very low possibilities of recovery, of a more life in a community. And very less money is given to self-care. So in this sense, we intend to clarify. I love that this was talked before about the rectory, but it is also to try to land more clearly what this rectory matter means and why in mental health we haven't seen throughout many years, among other things, because there has been an unlinking of the areas. It was first the addictions treated with more a punitive system, on the other hand, the pathology, not the promotion of mental health. So there was a conflict of understanding regarding what mental health states and the rectory, because it hasn't been executed correctly. So I would like to mention that is fundamental. That implies to give a vision and direction to the mental health sector, to gather data, to land the information, and execute programs in a regulated manner. Also, to show the different dimensions, which are these 6 points. Regulation, to observe the compliance of the legal framework, to promote health, a sectorial conduction, which is to channel the whole sector about these main functions of public health, already mentioned by Dr. Carmen. Then insurance, to guarantee the coverage of services depending on the needs of the population. financing to ensure this equal access to health services and to give services to promote the complementary and linking with other sectors so that the care, promotion, and prevention can be given to the population more equally and efficiently, especially considering that these functions, 3 of them, are exclusive to the government. So in this sense, we need to be clear about what we need to do as government, as a Secretary of Health, to organize in a better way and plan in a better way and assess, link, promote, and generate the policies regarding in all sectors. Also, it is very important to consider that everything that includes these functions, these 11 functions presented by Dr. Carmen, need to be implemented in a cycle, not only plans of actions, but also we need to understand the focus of the social determinants, mental, biological, to be able to detect the needs with an adequate assessment so that we can assign resources, develop public policies, and once we know the adequate actions to implement it very widely so that we can check these monitoring. So in this sense, SAP, CONADIC, and CONSAME have proposed in the Secretary of Health to generate the different programs to do this all together, especially that we are biosocial beings that need to include other factors, not only education, health, culture, tourism, economy, etc. This is why through this specific action that is aligned with the different documents from our legal framework, we propose 10 priority matters in addiction. They are here. I'm not going to stop in each one of them, but I want to mention that these 10 subtopics are not being addressed. We are working to promote, prevent, and give proper attention, research and capabilities. All of this because we know that at the end, the development of mental health implies a continuum. It's not that one day we see the pathology, but it's actually regularly when we diminish the protection factors or increase the risk factors, we can develop a pathology or the severity can increase. That's why it's fundamental to work with these determinants, focus in the individual, self-care, community, to do before the person arrives with this pathology to the unit care units. We know that many of the diseases of the disease load in our country has a comorbidity with mental health issues. So in this sense, it is fundamental to be very clear about the phenomenon of public health, which is suicide, that is actually escalating. And more than that, more than the suicide topic, knowing all of these concepts, we formulate a national strategy signed by an agreement between National Council of the 32 health secretaries to land the main lines implying this strategy, which is training of facilitators in the guide to intervene the gap of attention and link it with other sectors. The National Strategy for Addiction Prevention, which is a platform that allows us to link and add efforts in the different sectors to be able to strengthen these strategies and programs in a better way. And the National Program to Prevent Suicide that involves a series of factors, not only suicide or not only addiction or in pathologies, but it also implies a group of risk factors and the intention and the focus to balance all of this intervention so everyone has access to mental health beyond the pathologies. It also represents all of the work we have left behind, and we also have proposals for the Mexican model to restructure the different center of attentions at first level and then at all levels. That's why some of these programs have allowed us to go into the units and also at a second level. Some programs involving suicide behavior, so they can enter general hospitals so they have more knowledge about it. This is a very wide platform that allows the participation of different sectors coordinated from the federal government and also municipal governments through work tables and the Secretary of Health as coordinator. Also, we have the National Program to Prevent Suicide that allows us to have better coverage through national communication. This is the first program launched in the region of the Americas from the public system, which represents a great challenge as AIM-HCAP. So we're very proud because we have achieved this. All of this so we can land the reforms regarding this law. So we start operating all of this model together with the modifications to the general law. In May, it was published, this reform, and the 5 main points is the right to have mental health. The state needs to guarantee through the different programs we are achieving better scope. We also need to guarantee universal access and equal access. Then hospitalizations needs to be the last resource before there should be some other strategies to attend this therapeutic adherence of patients. Third point, psychiatric hospitals won't be closed because there was a confusion at a certain point, and it's going to transform more than just attending the pathology on mental health. We need to improve mental health in these centers, not as hospitals, although there will also be beds and in general hospitals. Fourth point, respect to human rights. Mental health issues has everything to do with human rights through many human rights. And fifth, coordination between the three levels of government to change to the new model. Our objective is to see this, which is an integration, not only of the public sector, but different organizations. We've been very close with organizations of civil level to counsel and train those who already work on this. And in the future, many matters that need to be implemented. One period is not enough. It's a work to medium and long term, but we're working firmly that are allowing us to start some of these actions. Thank you for your attention. Thank you, Diana. Thank you for your participation. Please, if you could stay online for a few more minutes, just in case there's a question. Also, I'm going to introduce Mariana Osorio Salgado to finish these presentations about the Rectory of State regarding mental health policies. She's a psychologist by the Autonomous University of Morelos. She's certified in first aids by the Barcelona University, and she's been trained for MHCAP and the INES and the services in the state of Morelos. She's state responsible to prevent and control addictions in the state of Morelos. Welcome. And the floor is all yours. Thank you. Good afternoon to everyone. I'm going to share my screen. I hope you can see it. Can you hear me? We can hear you and we see your screen. Well, first of all, I would like to thank the opportunity of being here. And I also celebrate the fact to share our perspective. We are in the Council Against Addiction from Morelos, and everything it has been mentioned. I'm glad to be at the end because I would like to show you the application on how we operate these systems and also being part of the history of this evolution. I'm not only been in these services for 26, but 13 years working from those starts of our country in mental health, with some CISAMES. I've been part of this evolution, so I'm very thankful of being here today and being able to talk with you about what's happening. Why to strengthen this sector of mental health?
¿Por qué fortalecer la rectoría en salud mental y adicciones? ¿No? Yo quisiera.
So why strengthening this? I know that it's been talked about some of this, but from our eyes, in the first level care, we see that the increase of non-transmissible disease with psychological diseases included have promoted this change in mental health and addiction. Anxiety, depression has increased, suicides, the use of substances, and the change of the use, decreasing the age, also more women and the increase of teenagers. So I'm very glad because it's been talked about some terms like the biopsychosocial model and determinants of health. From the vision of first level care, it's very important to have the relationship between the physical and the mental. These diseases are being the first cause of death in the world, like cancer, diabetes, and mental health disorders have a risk factor, the use of substance. And this relation between the physical and the mental allows us for people to knock the doors of this first level with other disease, with the comorbidity. They don't present with their mental disorder or the use of substances. Is there hypertension, high blood sugar? And this vision we need of the link of physical and mental is what we allow that first level physician is to focus its research, because it is important because it impacts to staying with the treatment. It's easier to tell the physician that these patients, they're gonna develop a mental health condition when they receive a diabetes, a warning, or cancer. And it's very important to take care of mental health so that they can stay in treatment, because we know that non-transmittable disease elevate health costs. 70% of deaths are because of this disease, and it's in productive population ages of people in productive age. So we need to really look mental health linked to these social determinants. And the important thing is to attend risk factors as the use of substance that increase the severity of these matters. We also have extraordinary events because urbanization, the non-healthy lifestyles, all social factors like violence. So these events like earthquakes, forced displacements, or a pandemic like the one we had, it's obvious that this is going to provoke some changes in the mind of people. And we're going to measure our capabilities, and we can see mental health issues, increase the use of substances. We've seen some studies how after a pandemic we're having a lot of psychological effects, ending in risk conduct like the use of substances, risk sexual relationships, and violence. So to adopt and implement these public policies, there is no public policy without will, without persons or institutions with commitment that operate them. And public policy is not a linear process. It's a social practice that comes from necessity and comes from the creation to be applied. But also sometimes these are actions already being executed taken then to be a public policy. We've had history of these public policies. Some of them have been done only by, from the desk and are centralized where the urbanization is, where there are a lot of resources, where we can apply it more easily because they want to have more resources. They're not going to go to the furthest town of the country to apply it. They want to have where there's more access. So we also talked about the determinants and the biopsychosocial model. And I think this is the phrase that summarizes. This is me and these are my circumstances. These are some meditation phrases. It has to do with that. We are determined by our context. So in this sense, public policies, what we're doing right now with the reform of the different articles to the law, it allows mental health and addiction prevention to have priority, and that universal and equal access, focus in communities, viable, accessible, with assessment indicators. They look for maximum benefit, guided by experts. There we can see Dr. Quijada, Gary Sabiki as these leaders, but that come from the field, that work at hospitals, units where they could see the reality. And today, these policies are done by these experts. So these are dynamic and flexible and adaptable, doing everything we can with what we have. I would like to show a little bit of this because everything I've heard today, I agree with. Yes, that's the path we're following. I see it in the community. But with these 4 aspects, I would like to mention what we're doing in Mexico. I just want to mention these 4 based on human rights. Mirror table, a program of therapeutic justice, mental health network, and increase of services. Regarding mirror table, in all of these measures, we are improving human resources, material and economic resources. And it's not everything in health. Here we can see the participation of other institutions that add the resources to achieve all types of communities, where we're giving protection factors and decreasing risks to increase mental health through peace culture, creating safe spaces where not only mental health givers, but all the promoters, sport and cultural promoters, even public lighting, all of these efforts is giving these safe spaces to the community, but also creating awareness, all of those outside of the professional the health system, to promoting, detecting
de salud mental. Entonces,
to this network. So this mirror table with directory of the Secretary of Health have achieved the work of everyone with their own resources. These are not just words, not only what we can have. This is an example in communities where they participate, they get involved. We see them cleaning, working in team. They don't need uniform. They don't need they just need the space and the ball to achieve, to create a space where the children goes from a video game or TV to be able to work on their mental health in a healthy environment that is going to produce in their brains the substances to be well, and the participation of culture. He is the leader of this place. And here we see the theater and the people. The people want that and they need that. And not only that, I would like to share, they did their medical. We're here with CNJ and other institutions taking activities to the children. People saying thank you because I was bored and I have nothing to do at home and I really enjoy these activities.
Look at the conditions under which we have the educational workshops, such as women in depression. We see it is the backyard of a lady that landed in her community, or the soccer field where we have these workshops. This is the sample of public policies applied in the territory. What happens with other policy, for example, the Therapeutic Justice Court? We talk about vetting or removing that idea that someone that commits a crime under the influence has to be considered not from the legal point of view. A right has to be provided. That's why they are fundamentally human rights, because it means giving a right to have access to health and to visualize addictions from the judicial system as a disease. So it is very important to destigmatize, in this sense, those that commit a crime, thinking that that crime could be committed due to a disease, giving them the opportunity not only of this, but to do the resource addition by the participating institutions. It is once again a program where we see the participation not only of health departments, but also the Public Prosecution Office, UMECA, the Unit of Precautionary Measures, the Judicial Courthouse, also the State Commission of Public Security, and we all add up to be able to carry out and implement this policy that gives an entire new vision to the substance abuser and that generates opportunities of change. I won't deny that there are people that reoffend, and yes, that they will have to have the necessary justice measures applied to them, but we've also had some success cases. These people not only receive attention in mental health. Diana Tejadilla was always talking about the vision that we have of public policies in mental health and addiction. This not only bring attention and support, but also looking for a way to influence in those aspects, providing social support, for example. This participant was able to have his INE handed to him. These people come from complex situations, and he didn't have this document. He hadn't been able to process it. So here we see an audience receiving trainings. These users are receiving training on what substance abuse is and what their disease means. So we have a physician here, a psychiatrist, giving this training. This psychiatrist does not only have a job at the psychiatric hospital. He also has a job in general hospitals. He has a job in the first level of attention. This psychiatrist is providing training to the users of the therapeutic justice program receivers so that they understand why they are sick, so that they know about substance use and abuse, and so that they know why we can commit a crime under the influence and why we see how other institutions add up to provide support. For example, we see this user that now has a soccer team and that soccer balls were donated. And this means bringing the public policy to the field. And what about the mental health network? Units are not being created out of nowhere. These were units that already existed. Mental health networks are units that have been structured and added. But it was an existing structure where we had these human, material, economic, structured, and agile resources. So we see a reduction in stigma because I don't have to go to a psychiatric hospital, but I can go to any health center, to any layer that will be called, to any capa that will be called General Hospital, CISANE, but not a hospital that's labeled for mental health. We prevent disease chronicity, hence dysfunctionality. And we provide attention to suicidal behavior. This is a sample of what the state of Morelos has achieved with the mental health network. Currently, we have 120 cores in one jurisdiction, which is the most urbanized jurisdiction. 68 cores in jurisdiction 2, which is the south neighboring Guerrero State, and 110 cores in this area, which is a mental health core. And this means a health center with a physician specialized in mental health problems. They have been trained to provide services. We have mental health mobile modules distributed around these stars, and these modules are psychologists in health centers that are providing support to priority conditions in mental health, depression, anxiety. We have 3 CISAMES in the state, which are these circles, trying to cover the region. And these CISAMES are the Mental Health Comprehensive Center, CISAMES. Here we have a psychiatrist and a social worker and psychologist group. And we already have at least 3 general hospitals with psychiatrists and 2 hospitals, 2 specialty hospitals, for example, for women and for children. And we are also providing neuropsychological help accompanying psychiatric hospitals. So these networks is a clear sample that any population could have better action. If we see this star here in the MOAC and Xochiapan are neighboring Puebla, and the nearest by CISAME is 1 hour away. So they have a health center with a psychologist to receive attention and support. So this is what, at the end of the day, means increasing the capability and the capacity of these mental health centers with the MHGAP guideline training, the telementoring, the telemedicine, the groups of emotional support, and drugs for first level attention access. There's a lot to do, but there's still a lot of work to do. I know, and it has been said before, we need to have some influence in the professional careers of health professionals, strengthen the first responder. Sometimes that first responder doesn't have the right input for this type of situation containment. If they have some psychiatric urgency, open sensitive beds in general hospitals, not only for the attention of other diseases, but also for mental health problems, and strengthen with drugs the first level of attention, as we saw in tobacco module. We are still needing treatments for tobacco or implementing tobacco techniques. Morelos just raised their hands, and we are very close to having the project of our first working tobacco clinic being approved in 2023. Thank you so much, Dr. Paredes, for your coordination. No, I am thankful with you and with all of the participants. Thank you so much for all of these expertise that you can give us and that you have given us. Now we will start with a couple of questions. We have some minutes left. There are many congratulatory comments in the chat for your participation and presentations. Many of you have talked about how proud you are of belonging to this revolution. So I would like to start with what could be the strategies that could be developed in order to share stigma, in order to eliminate stigma in mental health support requests. How can we improve this aspect? And how can we implement these policies to be able to have strategies in this sense?
De manera abierta, quien quiera levantar la mano.
This question is for any of you. Diana? Sorry, I didn't really listen to the full question. My internet was failing. Is there a strategy to fight stigma over asking for help from mental health professionals? Is there any strategy to be able to do so? Yes, actually, as of last year, we launched a strategy, I See You, Yo Te Veo, to reduce the stigma in mental health and addiction problems. We are trying to reactivate that campaign. Sorry, that was in 2021, because it was an entire week where we were talking about and providing information about it. And through community radios, we are doing this interrelationship. We have an entire department so we can reestablish all of these topics on stigma, and simultaneously via the emotional support groups. Well, this is a community initiative that entails psycho support. It is a calendar that's launched in every state. In some of them is doing better than others, but we are strengthening this strategy that's targeting the population. There are also some aspects that have been discussed in terms of stigma, facing the different problems of mental pathology, but especially with a focus on mental health. What we are aiming is to have 2-hour-a-week session talking about these 10 mental health priorities in 15-20 minutes in a very simple language, and then the population could ask questions and share their concerns so they can be addressed properly. Thank you very much. For Dr. Carmen, how can we reduce the therapeutic gap that we talked about in your presentation? Well, we would need a lot of time for that question. I wanted to highlight that these presentations have been great, especially Diana's and Mariana's, for providing so specific examples of the progress that they've been having with that hard work in Mexico. And actually, to reduce the gap, we need several angles to be addressed and interrelated. And it is clear that the strengthening of governance via those public policies and plans and laws and legislation, and they are doing a great job in Mexico about that, but also, as you say, from the territory in different fields, without forgetting to identify the specific needs of the population. Not everything can be reproduced everywhere, and mental health system, the way it is developed in each specific region, in each municipality, is fundamental. And I want to give you an example. Psychiatric hospitals. Diana was saying, We are not going to close them down. Let's not be worried about that. The message in general that we are sharing from WHO and PAHO is towards closing psychiatric hospitals, not just because, but because we need to go towards those alternatives that have been very clearly explained, that long-term should mean that we won't need them anymore, but it is a transition that requires a lot of steps, and we need alternative services. For example, let me give you some examples that haven't been discussed. Community residences, temporary safe houses. In the integration of mental health, we have on one hand mental health communities, and from the first level of attention. Then we have other elements. But if I had to sum them up, these would be the main elements to reduce the gap. And I was talking about halfway houses, halfway houses. And here they are also talking about the question if Mexico is already providing coverage to mental health problems. If not, what can be done? Well, we have been seeing this very concretely in this presentation. There are also questions, more specific questions, on what are the sensitization and training programs from communities in order to address cognitive impairment in communities that are farther away. I don't know who could tell us a little bit more about this. Well, something that has already been launched simultaneously or after the MHGAP training is a national program of telementorship that allows, after the training of clinicians in first level of attention, to have that open window with specialists in mental health of these disorders that could be a little bit more complicated, and it is more complicated to reach these units. That's for one thing. We are also just starting the program of telemedicine with the two main psychiatric hospitals, Navarro, which is a child's hospital, and the Fray, which is one of the most important hospitals in Latin America. All of this is a long-term project. However, if units request it, we have the right connections to provide an answer, a response to the different situations that could arise. Another important topic that we have here in the calendar, let's say, is a mental health desert. We are tracing where we still need trained staff. We don't have enough psychiatrists or psychologists to address the country. So we're working with other profiles, other health profiles, so that they can have access to it. We already have that a huge number of psychologists at the FIT have received training, and we are implementing that these psychologists trained could go into the mental health brigades. But the idea is for all of FIT units, we already signed a couple of months ago with the director, Nuri, to be able to bring this training to all the FITs, which are more than 1,000 units around the countries, and some others that are more specialized ones. And we are about to begin training to caravans, the strengthening for medical attention, because these are 741 mobile units that go to small towns of up to 2,500 inhabitants. So this is the way in which we can have access to these communities. Thank you very much. A question for Mariana. Human resource is a reality that's focused in some states, and the distribution of services is in urban areas. You talked about how to work with this distribution to be able to reach further areas. Why do you think that this strategy is done in Morelos? What would be the qualities that had helped succeeding, and how could it be reproduced? Thank you, doctor. But I believe that could work very well. I was saying betting on physicians' training and education. Today, the general physician doesn't have education in psychiatric and psychology. So something that we think worked is coaching general physicians. General physician is still finding it a little bit hard or afraid to face the mental pathology, even drug-wise. They are afraid of prescribing or addressing them. So I think that's something that has worked is implementing the MHCAP guideline training, but also accompanied with clinical cases, with permanent training, and we have psychiatrists in the state. We invite them to help coaching on how drugs should be applied. This has helped general physicians a lot, and this has been a 2-year process. So I am betting on general physicians to still be our strong point. They go to all corners, and we haven't mentioned this before, but we have Diana Tejadilla. We have also interns and pre-grade physicians being assessed in mental health. We are offering the opportunity to do a screening and to address them because we know the health professional also gets sick. And this provides certainty to that physician, not only to get prepared in mental health, to address others, but also visualize their own mental health, their own substance use and abuse in health professionals. So we bet on training of these general physicians that are already in all corners of our country, but we have to provide support. And this would be my answer, and this will help a lot reduce stigma in population, because in a health center, they could see their depression as they could see their flu or any other disease. And to conclude, Dr. Molina, you mentioned adding efforts for governance. How can we integrate society so they can add up to these efforts in pro of governance, and how can we improve these efforts? Thank you so much. It is not an easy job. It's the first thing that I want to tell you. And it is a long data work. We need to have a permanent effort. First, we have to deploy an important information effort. I think this information is hard. Also, sensitization in specific case of mental health and how problems affect us, as well as human rights. That has been addressed in other panels. We have to address government, states, so we can include them in the explanation of other sectors and other authorities. But we also need to significantly go to the other extreme, health committees in first level areas, and to provide a certain emphasis. Now, this is the same recommendation that we would give to vote on chronic diseases and other emerging diseases, infectious diseases, in a high transmittability. So it is the struggle, the usual struggle, and something that has been very well mentioned by Dr. Ora, the health professional. She was talking about the physician. I would also talk about the nurse, the infirmary division, nurses. We need everyone to know more about mental health and how to address these problems. They need to be better prepared, and we need to start from college maybe a little bit before. And of course, those that are already graduated and in the system to generate the right training for it. But it is a never-ending work. It has to be. Thank you so much. I would like to thank the participation of each and every one of you. Thank you so much for strengthening all of this information, all of this need. And at the end of the day, this is gonna help us have a coordinated effort that we can see reflected in the population's mental health. We would like to thank you for your participation. Thank you so much, Dr. Francisco Paredes Cruz, for moderating this interesting roundtable on the importance of strengthening governance in mental health and addictions, adoption and implementation of public policies. And we will meet again tomorrow at 8:30. We'll start with our conference, Mexican Model of Mental Health and Addictions, Mental Health Attention at the Health System by Dr. Jose Javier Mendoza Velázquez, Director of the Coordination of National Strategies in the National Commission of Directions in Mexico. Thank you very much.